2, est-ce qu'il est ouvert? Ouais, merci. Voilà, je vais inviter tout le monde à regagner vos places assez rapidement, s'il vous plaît, parce que vous imaginez bien qu'avec le contexte sanitaire, on a changé un peu notre manière de faire par rapport aux autres années. On a beaucoup de monde en duplex tout au long de la journée. Donc on va vraiment essayer de respecter le timing parce que les gens nous attendent à distance pour prendre la parole. Voilà, je vais laisser les derniers s'installer dans cet amphi. Et puis ensuite, on va fermer les portes définitivement. Alors, idem aussi, je sais que c'est toujours compliqué, mais si...
So I know that this is a request that we keep asking time and time again. Can you please put your mobile phones on mute or silent and try to avoid using too many devices? So we're going to try and do our very best as to avoid the technology to just crash down on us. Amongst the other information that I would like to share with you, well, first I would like to thank you for being here. There are headsets for you to listen to simultaneous interpretation. French is number 1, English is 2. Obviously, as it was the case in the previous years, you will have an opportunity to ask questions. There will be a roaming microphone for that. Unfortunately, this year, because of the sanitary crisis, when you speak in the microphone, there will be someone holding the microphone for you and will be wiping down the microphones in between each speaker in order to sterilize it. Now, I suppose that you all have smartphones or tablets. So this conference is going to be streamed live on ODES website. Well, I'm going to try and avoid speaking Fringlish, says the speaker. So you have an opportunity on our website to listen either in French or in English, and there's also a chat panel. So this is a panel in which you can ask questions or you can just say hello, and hopefully many participants will take part to that conversation. Now it's 10 or 3 minutes after 10, so we're not lagging behind too much. So I do invite the last persons here to take his seat, and in a matter of a few seconds we're going to dim the lights and start with the jingles. Okay, so no, we're not dimming the lights apparently. So if everybody is here, we're going to listen to our jingle. Hello everybody, and welcome to Andoise, the house of the Pierre Fabre Foundation in the Tarn, the southwest of France. I am very happy to open the 5th conference of the Observatory for e-health in the southern country. It was created in 2016 with the active support of the French Agence for Development and the University for Francophonie. in the current context of COVID crisis, we know that we have to operate with a number of restrictions and borders being closed down. However, we were able to continue our work because we thought that it was all the more important in this period of crisis, and we did so by leveraging all the potentials of digital solutions. So we have changed the format of this conference with a combination of people being here and people being remotely. We also have a strict sanitary protocol, and we also have strengthened communication means, which will make it possible to dialogue with 10 of our speakers. The observatory works all year long to try and spot, but also document initiatives in e-health in Africa and in Asia, which make it possible to concretely improve access to healthcare for populations, especially the most deprived population. To date, there are 160 initiatives in 80 different countries that are listed on the database of our observatories, which you can access on audace.io. 34 of them received awards from the observatory, and 5 laureates will be showcased today. Our objective is to help with the development of solutions, but also of their ecosystem. So we try to disseminate knowledge and best practices, and we try to align those innovative solutions with public health priorities. Now, this year, COVID crisis was first on the agenda, the world agenda, but also our agenda. Since this spring, we've been following very closely the adoption and development of digital innovations in the context of the sanitary crisis. So this will be one of the hot topics of our conversation today during this conference. Before I give the floor to Mr. Kemp first, a representative of AFD, then Professor Slim Kalbus, Rector of AUF, I would like to wish you a very fruitful conference.
Bonjour à tous.
Hello everybody, my name is Pierre Kempf. I work at the Health Division and Social Protection for the Health Agency, and also I'm a focal point on a number of e-health topics because I'm a stand-in for Anne Roos, who is expecting a baby. This morning I'm very delighted to share a few words of introduction with you. So this day will be dedicated to digital in health. I have a hard time saying digital health because I think it's a poor translation of e-health, and digital health for me sounds like robots health. First and foremost, I would like to thank our host, the Pierre Fabre Foundation, and especially our General Director, Ms. Garrett. This year, I do realize all the hurdles that we had to overcome, also the uncertainties, before we were able to take part to that meeting today. And obviously, it's a massive success. So I would like to thank all the organizing team. So it's a day during which we're going to exchange, but we are also going to showcase a number of projects, a number of innovations that were handpicked by the association, by the foundation. I would like to thank the teams, but also the sponsors. And as you will see, those innovations are definitely quite passionating. Well, COVID-19 crisis is first on the agenda, is a massive source of concern, is also in all media. Obviously, it's difficult not to talk about this sanitary crisis today. So it has been and it still is a world crisis. All health systems were shook at their base, and we need to remain humble and clear about this. On the other hand, the crisis did shed some light on a number of challenges, and I think it's going to demonstrate the interest of digital tools in the framework of such crisis. More generally speaking, I'm going to discuss three aspects that became clearer during this sanitary crisis pertaining to e-health tools. Of course, how we manage epidemiological data and all connected subject matters. Operational management, you know that because of a crisis we had to coordinate care, to manage appointments, to provide test results. So there was a definite operational side to the crisis management, and also ITCs were very important to inform, prevent and alert. However, the crisis also highlighted that the road ahead is still very long and with many hurdles. A few more points that I think are very important to tackle with you. First, I think there's a political framework that we need for it to structure those digital tools. This political framework should aim at superimposing the different different public policies. We need to have a very strong will from the national government, but also the regional organizations or the world organizations, and also NGOs. Those need to create the proper platform for the right development and for further experiments, because obviously it is impossible to have such technologies between widely accepted without such a framework. We also need sponsors, financial sponsors. Becoming digital means an investment which requires also underlying social transformations. To do that, AFD has a number of tools, financial tools, so we can help entrepreneurs through personalized support. We can finance the development capital via our subsidiary Proparco. We also have financing to a kickstart and an incubator as well. And we have a platform of entrepreneurs which is named the Digital Africa Platform. Third point that I would like to mention, I think it's important to work collectively. It's important that we have a network. You are representative of this network here and also remotely. This is really our essence. This is the energy that helps us moving forward when it comes to digital. So once again, congratulations to the Foundation, but also to other players who have played a major role in that. AFD is proud to have helped in this collective endeavor. This year we renewed the partnership contract that we have with the Foundation, with Ms. Garrett and my colleague Perrine Bonvalet. We were able to continue this partnership, and I would like to thank both of them. Now, before I conclude this introduction, maybe I'm going to say a few words about AFD. So AFD stands for the French Agency of Development. This is a public body which finances development projects. We intervene in 109 countries. In 2019, we financed more than 1,000 projects for a total of more than 14 billion euros. Those projects fall in different categories, be it in the private sector, in the energy field, urban development, sewage, social protection, education, to name but a few. if we want to break down the support that we provided to those different areas, about 5 billions of loans to the states, 5 billions of loans for companies and collectivities, 2.5 billion as subsidies for projects, and 1 billion as guarantees and participations. So this is how we used up our budget last year. 50% of those subsidies and loans are targeting Africa, which remains a continent which is very close to our heart. Once again, I would like to thank from the bottom of my heart all the players at the Foundation, and I would like to wish you again a very fruitful day of discussions. Thank you very much.
Monsieur Slim Kalous, peut-être.
Mr. Slim Kalous is going also to provide an introduction to this conference. Thank you very much. Thank you for giving the opportunity to AUF to take part to this meeting. AUF has been a long-standing partner to the Foundation, especially to the Ehealth Observatory. We've been one of the founding partners, and I hope this will be the case in the future going forward. And we're delighted to see that this smaller project has now become a reference platform, and we're very proud of this. Now, a few words to present what AUF is, then I will give you a few examples of what we do in the fields of health and digital. We are not an association specialized in health. We also have a number of projects in the areas of research and education. And finally, in the third part, I will tell you what we do in the framework of the COVID-19 crisis. So AUF stands for the Association for Francophonie. So this is an association which helps with networking, which also leverages the different projects of research worldwide. So we support French-speaking scientific communities and how we can disseminate scientific research thanks to the French language. We are considered as the first network of universities in the world, with 1,007 universities from 109 countries in the world. And this, of course, means a lot of responsibilities for us, and we strive at helping South-North relationships. We do many things in different areas connected to university, research, education in general. We focus very much on digital in health sciences. I'm going to give you a few recent examples of projects that we've supported in the last years or so. First, we help and support expert networks. Expert networks, as the name entails, we have a network of medicine schools in the world. We also have a network of different pharmacy deans. We also have a network of different dental schools. And in this network, we support a number of projects. We help with the accreditation of schools in countries of the South. For example, the Marrakesh Dental Schools was accredited in 2019, the one in Marrakesh and the one in Tunis the following year. And these were some of the endeavors of the AUF. We also help with remote learning platforms. We have programs with a number of universities, UNES, which is the French University for Health and Sports Health, and we also help with the development of a number of universities, for example, the Medical University in Haiti. We have a collaboration project whereby we try to have a digital division. So we're very present. There are a number of MOOCs that are created and disseminated thanks to AUF support. When it comes to education sciences, we also co-created associations or bodies. For example, in Laos, we have an association for French-speaking medical schools, and we work strongly with people in the country to have this institution become more digital. In the area of research, we collaborate with a number of bodies, to name but a few, with our counterpart in Quebec, to help access to care. We also help with research and development with IRD in France, for example, and then again we disseminate a number of educative material. We can also support the publication of books or magazines, for example, the Health French-speaking magazine. We also organize scientific events like the one you are attending today. The last big meeting that we organized was a colloquium in Brussels in 2018, where the main theme was the role of education and education to health and the contribution to health policies. We discussed back then the importance of e-health and e-health tools, which demonstrate, which is a topic in which we've been interested for many, many years. We also have a number of structuring projects in Morocco with the health ministry. We have a project whereby we want to help 1,000 radiotherapy technicians. We also have, still in Morocco, we support the Advanced Studies Institute on the impact on health of urban development and access to digital tools by the population. In the Ivory Coast, we also have another example. We're very proud of the creation of the virtual University of Côte d'Ivoire. So we supported the entire project, and we're also creating a Fab Lab in medical sciences. So this was an overview of everything that we do. The fact that we invest very much in digital, in science, health, in health science in general. Now, a few last words on what we did during the during the COVID crisis. Very quickly, we launched a crisis mitigation plan. We implemented telework or remote working for our employees, and so we used the tools that we usually use for our partners, and we used them in-house as well. We had 4 pillars: scientific training, so we had a newsletter which we sent on a weekly basis, and we would showcase all options and all projects that were available around the crisis management. Then we had a second prong: documentation. So we have a library, and this library is fed with everything that was published. This was a digital library which was in free access for all the members of AUF, and we had quite a number of people taking advantage of this free access to the library. The third prong was training. We made it possible for close to 1 year, for close to 1 year, in the last 12 months or so. We opened digital platforms which make it possible for students from the south to use that platform and make classes and courses available to their students. So a number of online courses or classes. It was a tremendous success. We have more than 800 such classes available. 40 countries use this platform the world over. But also, university in the north also develop classes and trainings for the south. So we have these double specificities of having this platform which is managed in the north, but we also have the possibility for students or researchers who cannot go to their university, and they can help with all bureaucratic tasks, registration, etc. For exams as well, there are digital centers, and also for students who do not have the financial means to have a high output internet connection, they can use the French-speaking campuses. So campuses where they have free access to computers and wideband internet. So thanks to that platform, we're able to deliver a number of MOOCs and certification of different diplomas. So the diplomas that are delivered by our universities are safe and fully recognized. The fourth prong, we also launched a call for projects in research and development. So this is a call to students, PhD students, and young engineers. And so what we'd like to do is help them, support them technically, but also financially, to develop tools with an immediate impact. At the beginning of a crisis, you may remember that there were no masks, that we did not have respiratory equipments, and so back then we needed to have such projects to potentially leverage what was already existing and maybe duplicate projects. So there was this call for projects. It was extremely successful. We had more than 2,000 people who applied from many countries. The fund was more than 1 million euros, and we were able to finance projects for from more than 40 countries. So this is what we do. This is the reason why we're very happy to be here. We're happy to support, but also be a partner of this observatory. And the topic today, I think, is very topical, and will be more than delighted to talk with all participants. Thank you very much again for inviting me, and have a very nice day. Thank you very much to Dr. Kaboul. Welcome once again to this new installment of his Observatory of e-health in the southern countries. So this is a very different installment because most of you are connected remotely to a platform. It was impossible for you to travel to Lavaux and be with us today. However, thanks to technical solutions, we're all going to be together nonetheless, irrespective of what or where you are today, in the United States, in Africa, or in Asia. This conference is maintained, and this is good news. I think it is the most important point, the fact that we can have those new technologies presented to us, and for us to realize that we've made progress year in, year out. We'll see how those digital tools are very much relevant to fight against sanitary crisis. This can be COVID, but also dengue, Ebola crisis, and obviously we didn't wait for COVID crisis to have tools and to have way to mitigate such crisis. So here we have a partnership with AUF. You just heard their representatives, and we are very fortunate to have people from the world over listening to us. So we're going to congratulate, for example, the campus in Brazzaville, the campus in the Great Lake region in Burundi, in Gaoundéré in Cameroon, in N'Djamena in Chad, in Kinshasa in the DRC, also in Lubumbashi, in Libreville in Gabon, in Libreville, also in Cotonou, in Ouagadougou, Abidjan in the Ivory Coast, Conakry, Bamako, Mali, Nouakchott in Mauritania, Dakar in Senegal. We will have a presentation. Lomé will have a presentation also from Togo. We'll have a presentation from Laos, from Vietnam or Cambodia. So there are many people taking part remotely to this conference. And as I said, we're going to start with a presentation from Laos with the campus from Vietnam.
Vientiane, on doit retrouver.
Okay, Vientiane, we will have Antoine Blancvitz. Can you hear us? Can you hear us from Vientiane in Laos? Yes, I can hear you loud and clear. How many people are you with, and what is the weather like? What time is it? It's 3:30. We haven't had much rain today. How many people are you with? How many people are you with? Now, who came to attend the meeting? Are they students, caregivers? People are just interested in IT? Well, we are happy because we didn't expect to have that many people. We have, of course, students, we have midwives, we have medicine students. So we have a wide variety of public, and they're all interested in e-health. So we also have teachers and from the pharmacy university. It's great to have meetings broadcasted in several countries. Now, this is broadcasted in French and English. You can select the language in which you want to have the meeting. So, Antoine, what is your expectation? What are the expectations of your guests? I think the subject of the meeting is obviously very attractive, and it's, follows current events. We have not had any COVID cases in Vietnam for over 2 months, but we do know that people are concerned, people don't want to leave their homes. And we know that countries such as Laos are very much concerned. Thank you. Thank you so much for being with us. And we'll see if you have questions at Vietnam. Now, for all the other people following us on the internet, if you have comments, questions, positive points, it's always good to have your chat comments. Very heartwarming to have all these messages. I have a first message that says, hello, we are the group working against sickle cell disease. Thank you. Then we also have a hello from Kinshasa. We also have Professor Auger from Niger. We are at the Health Center of Niger. Now we also have messages from Casablanca. So, we are followed throughout the planet. This is, of course, a conference that concerns everyone with the pandemics. So don't hesitate to say hello. It's always good, and it's a ray of sunshine. So now let's move on to the next presentation. How do tech fight against the epidemic? So we will focus on West Africa with Samir Abdelkin and Julie Landquin from Startup Bricks and Emerging Valley in Africa. So how do tech tools help fight the epidemics? So here we have Samir and Julie. You have the floor, and also give us very concrete examples. Hello, and thank you. Thank you. I hope you can all hear me. Yes, hello. Now, thank you for having invited us. I'd like to thank the organizers, the Pierre Fabre Foundation, and your resilience, your motivation, Beatrice, to say, yes, we will meet. We will have our meeting today. It's a great honor. Why? Because during this observatory meetings, we have been able to really go in the field and make sure that we are close to the populations. And today, more than ever, we see the purpose, the meaning of the tool that we've developed. It's inspiring not only Africa or French-speaking countries, but also the rest of the world on crossed innovations that definitely can help us fight in the epidemics. And really, it's the work that we have done during this study. It's not only because of COVID that Africa decided to come up with a tech solution. It's not now, a couple of months ago. It has been the case for several years, several months, a lot of innovations, but also the state. And we will develop and show you some examples. And let's keep in mind the example that was a flagship example using tech again to combat epidemics. In the case of Ebola, we had a massification of data with startups, with companies, but also among states. And we will talk about Nigeria. So here we see that Africa was ready to cope. It wasn't caught by surprise like other continents. And in my presentation, what I'd like to do is really focus on indeed the fact that the African continent, that is what we call the resilient continent. It's also a continent where we have a hard time finding doctors. The medical centers are hard to find. Again, I don't want to create a kind of image, but you know, if you look at the figures, we have 2 doctors per 10,000 inhabitants. Then we have the GDP also that is dedicated to the health cost for all African. It's not even 10% of the overall GDP. And then in addition to all this, we also see that there's a continent where IT, with tech, with the mobile device has been one of the path breaker. And thanks to that, we have been able to develop new uses. And that explains why Africa is at the leading edge of IT for prevention, for new apps to inform on how do you have a diagnosis, how do you get information, how do you have notifications to really recognize. Now, this is typically in the observatory, we see hundreds and hundreds of apps developed in Africa that are really aiming for this, to try to educate, raise awareness. And that type of tool that we only see coming in France, we have had that for over 5 years in Africa. And let's not forget, and we're going to try to pinpoint this, e-health in Africa is really taken seriously by the investors. And one paradox during the lockdown, during the breakdown of economy, we saw some investors traveling to Africa to invest with several thousand euros, over 100 million euros, I believe, have been invested in e-health innovations, especially this kind of situation. The idea is to scale up the innovation. Of course, it goes with support, with financing, and I think it's also a proof of concept in our market, in our country, that has been revealed by the pandemics. I'll hand it over now to Julie. Hello, thank you, Samir. Thank you, everyone. So thank you, Samir, for introducing our project. I think it really lays down the framework that what we have done. Now, what we've done is for 3 months, April, May, and June, we have been able to fuel with data, with also tech responses to the health crisis that we have had to face. At the time I was living in Nigeria, we saw that the borders were closing one after the other. But what we've also noticed is that there was a boom of technology. The idea was to try to reduce this crisis. In 3 months, we've had over 180 actions, tech actions in Africa. And of course, this is not going to stop here. We're going to try to introduce this and show this to you first with Ebola, because I think with Ebola, this is where the tech solutions have started. Now, the study is not just today, it's even before, in 2015. I don't know if you remember, but Bill Gates had a visionary speech who also talked about the new outbreak and said that this new outbreak would put a pause on the planet with a lot of victims. What's interesting is that at the time he spoke about Ebola. And he said it's not nuclear wars, it is an epidemics threat. And even at that time, he said that the public authorities would not be ready. And so he said that governments should get ready with technologies, which really urged us to create this study with Ebola. Now, if you look at 2 years, between 2014 and 2016, we had a real quantum leap in technology. So we went from 25% to 33% in only 2 years. So a major advance. And that means that all the teams that would manage these crises would have at least the mobile phones to follow the contact people. We spoke about Sierra Leone. Why? Because in this country we had a lot of Ebola cases. The mortality rate is very high. Now, it's not only with technology, but the minister of the time in Sierra Leone, the technology and the mobile phone had really helped reduce the cases. But of course, this solution, it really came from Nigeria. It was a perfect example. In 93 days, the country has been able to really get rid of the Ebola virus. When the first case at that time got detected, we had 23 million inhabitants, so the city is unmanageable because a lot of dumps, no one believed that we were be able to remove the virus. Now, with technology, we have been able to react very quickly. You see the curves. You see the curve that flattens out. That's when they started using the mobile app, which is called eHealth Ebola Sense. It really is similar to the app that the ODS has developed. It uses the same software. And as the minister at that time said that he saw that the cases reduced and the percentages. So you know that when you are fighting a virus, you're fighting against time, and this is essential. So Ebola has shown that technology against epidemics really occurred even before the COVID. This is the study that we carried out during different continents, so only initiatives versus COVID, all the countries of the African continent. And these are cross-cutting, transversal, I would say, initiatives. I think that's the difference between Ebola and COVID. So all the sectors, the economy, society, and we try to show you the various actions, the initiatives that came from these 180 solutions. For example, of course, the makers professor has talked about this, the Fab Labs. So from South Africa to Maghreb, West Africa, East Africa, this is in Sousse, the startup 3D Waves. You see that we have printers. So we had really lent the printers to the engineers. And so the idea was to print visors. And that definitely is a great help for health caregivers that are on the first line of the virus. Another example that really shows what we've done, the mobile apps. Often it's e-health startups, but not only. This is the case with Brenco that designed this application. So in fact, you can inform quite simply on the software. It's a step-by-step form, and according to the symptoms, they tell you if you are at risk or not, and it's a way of reducing the number of ER cases, because people were so concerned. What they did is that they called, they went to the hospitals, and a lot of similar applications really made it smoother in terms of management. And again, that is similar to what Odes has said. And at the time of Ebola had yes, so you also anticipated that. Okay, now another example that what we find is when you work hand in hand with the health authorities. Here you have mobile operators and tech startups. You can visualize where populations are moving, and again, that was done at the time of Ebola. Another example is very logistical. This is again to manage smoothly the crisis. In Kenya, you can locate the ambulances in the country, so that means that you can send your ambulance to the most urgent cases of COVID. On the right, you have all the beds of intensive care units, and also 600 health caregivers, nurses didn't know what to do with COVID patients. So you see a great solidarity. But it's not the only example. There's a, huge number of applications in Nigeria. We were able to deliver with drones of COVID testing in rural areas, with cities being able to diagnose. M-Pharma in Ghana has been able to connect the pharmacy with the wholesalers to once again have a better management of the crisis and avoid contacts. And applications like that, we have a high number of applications like that. Okay, we speak a lot about tech responses and solutions in the case of epidemics. But we see that in France, there's also the business, the economic. There's the first shock. Every day we have debts, but we also know that we will have what we call a snowball effect with the economy, with bankruptcies, poverty. And what's interesting is that in just a couple of weeks, we saw the development of the social approach of the epidemics by the African tech. This is to answer to this. So I'm speaking of in front of the deputy. They say, do we have a minimum universal revenue or salary? And so we see that in Western countries, in Europe, but in Togo, they did that. In just a couple of weeks, they set up a program to support the vulnerable populations. This is a program called Novisi. In a way, it means solidarity, and so that helps us and helps them cope during the lockdown, to really stop any physical contact, but at the same time to be able to digitalize the payments. This is because World Health Organization said that any notes or coins has the virus. So this program in Togo, through the mobile banking, you can pay. So in fact, your phone becomes your credit card. Your SIM card becomes your SWIFT. And so the state has sent this to 1.2 million citizens, which is incredible in just a couple of weeks. So they sent us a lump sum to help the population and also encourage them not to go to work because, you know, in Togo, you have taxis, you have people working on the streets and so on. So the government said, we will give you some money, but you won't go to work. You have to respect the lockdown. You have to respect the times and really break the epidemic curve. So this has been also supported by Esther Duflo, Nobel Prize winner, and this has been developed and very quickly tested, rolled out in Togo. So there are some projects. For example, Morocco has developed a similar project. And so this action was to give to the household what a minimum sum of money every month to help these families, cope during the lockdown. And how could they survive during this lockdown? So here we see these various new habits, if you like, that sometimes, we think about it for 5 months, 10 years, 5 years and 10 years. So when you are facing an emergency situation, you've got to cope to survive. And when states start innovating, in just a couple of weeks, they could really come up with breakthrough solutions. So we'll conclude to that. Several recommendations have been drawn from this study. We'll show you a couple. What we've noticed is always make sure that adapt your solutions to local needs, whether it's non-connected features, languages also, having also oral voice modules so that people who can't read can also have access to these populations. And also upstream, try to work hand in hand with the health authorities, the tech ecosystems also, and the supporters, the financiers, and also the corporate. And also what we also see is to encourage this type of study to bring out best practices and the most relevant solutions. What's really important, and I find is incredible, is when we see the ecosystems, for example, the prize winners, the award winners, and we will have that, startups in Togo or even in other countries. This is really at the leading edge of this fight. One example, you know that Mali is going through a horrible political crisis. And despite that, even today, there's a hackathon against COVID that is organized by local communities to be able to cope with the pandemics and helping citizens better fight it. We also see, and Julia has said, there's a need to raise awareness, to evangelize, and populations need to embrace these new technologies. And we have also been able to see the media. Of course, the media have played a strong role. We can congratulate them to really talk about these new initiatives. You know that the ODS platform, that was also a pathbreaker because we started working with ODS 5 years ago. So here we have a good momentum. Media are really taking things seriously, and I'm sure that in the room we have Fichenja, the special COVID, this type of action, this type of initiative that really boosts the ecosystems, drives the ecosystem to better achieve their goals. And this will be my take-home message, and I believe that this is essential, the financing. How do you finance? How do you enable these startups, these entrepreneurs to scale up? We spoke about M-Pharma in Nigeria. There's a lot of funding in the e-health area, and we see that in less than 2 years, the startups in e-health has increased by 50%. So basically, we're talking about a very mature market. There's also a community of investors. Of course, they were reluctant during the COVID, but now they believe in African e-health. For example, Ilium Health, this is a platform that creates a digital path for the patient and also really has a communication with remote populations. M-Pharma, Julie talked about this in Ghana. 400 pharmacies in Accra has raised 17 million. International investors, that means that these are not local investors, but from home, from Silicon Valley or Europe, they see already the potential, and they say that this potential can definitely work also in Europe or in their country. 54Gene just funded $15 million. So I know we have a timing schedule for our presentation, but I think that the take-home message is really to really see everything. And again, I'd like to congratulate ODS for the wonderful work that they've done in the past 5 years. And it's also great and heartwarming to see what's going on in the field. Thank you, Samir. Thank you, Julie. Thank you for this presentation that is, number one, fascinating, motivating, and very concrete, because we see the initiatives that are everywhere. I know that we have questions. We have questions on the tablet. I'm convinced that we have a lot of comments, questions following this presentation. So don't hesitate. We have a chat. Don't hesitate to get and ask your questions. We will have questions for Julie and Samia just before, because we are discovering, let's go from Africa to Asia to really share the experiences. So we'll go to Taiwan now. Taiwan, where we will have Dr. Di Min Pang, who's the General Director, Department of Management Information, Ministry of Health and Welfare. Doctor, hello. Can you hear us well from Taiwan?
Yes, I can hear you. Can you see me?
Oui, allez, faites-nous voyager un petit peu. Quelle est la météo aujourd'hui à Taïwan et quel est...
What is the weather? What time is it? And how's the weather like?
It's cloudy day.
C'est bon, alors il n'y a pas qu'ici à Lavore, on a quelques nuages qui traînent. Écoutez, docteur...
In Lavore, it's cloudy also. So it's a great honor to have your presentation in Taiwan.
Okay, it's my floor to show my presentation.
On va la voir, elle va arriver tout de suite, votre présentation. Et on va vous suivre au fur et à mesure sur vos diapositives. Hop. Vous pouvez commencer, hein, docteur, on va vous suivre, on va...
You can start, and we will be going through the different slides as you speak. So you can start. Thank you.
Voilà.
Hold on, please. 多謝啊！我啲針。
Allez-y, on vous écoute, on va les faire passer.
Okay, so we listen to you. Please do not hesitate to start, and we'll be managing the slides for you.
Alors, est-ce qu'on peut passer peut-être à la diapositive suivante, et comme ça le docteur va pouvoir les commenter.
Okay, so we're going to show your next slide, and then you can start your presentation.
Oui.
Good day, my dear friend from different country. I'm Yimin Pang, the Director of Information Management in Taiwan's Ministry of Health and Welfare. And it's my honor to share with you about how we apply information technology to respond to the evil COVID-19 epidemic. The coronavirus first broke out in Wuhan, China, just before the festival of Chinese New Year. We suffered very much from previous SARS outbreak in 2003. The experience helped us to react faster and take the danger more seriously than in other parts of the world. In response to the severe coronavirus outbreak in China as early as January 2020, the Taiwan CDC, Center for Disease Control, officially activated the Central Epidemic Command Center and quickly instituted approaches and actions such as the mask rationing plan, border control from the air and sea, proactive case finding through traveling history, case identification, and quarantine or isolation of suspicious cases. We apply information technology to enhance all hospitals look like bunkers or important army bases to keep away from nosocomial infections. We try to make everyone in Taiwan, no matter Taiwanese or foreign people, can purchase surgical masks very easily and to keep social distance effectively. Maybe you knew we have a very powerful cloud system to act as a platform of health insurance sharing for national health insurance. On the platform, both insured and health providers use smart card to be the identification tool. All computers are connected by virtual private network. Before the pandemic, according to this cloud system, our physician and the pharmacy checked patients' medical record, including pharmaceutical, examination result, surgical record, and etc. Based on the existing system, the National Health Insurance Administration extended the function from sharing health record to share TOCC to physicians, clinics, and hospitals. Travel history means inbound record from immigration department. Occupational means health worker, long-term care worker, and pilot and flight attendant. When we decided to let everyone in Taiwan can get facial mask equally and easily, the National Health Insurance Administration modified the cloud system to write down the purchase record and to keep everyone can buy 3 pieces of mask in 1 week at initial time, and now can buy 9 pieces in 2 weeks. Around the beginning of February 2020, for each traveler arrived at Taiwan, we can share their personal ID number when they visited physician. But it was very difficult to instantly correct the accurate contact information for example, mobile phone number, because all health declaration and the home quarantine process rely on handwriting and the paper delivery. At best, delivered by email and recorded by the Microsoft Excel spreadsheet. Day by day, the traveling areas and the population expanded from China to other parts of the world. It means the original artificial process may be collapsed at any time. We decided to set up a comprehensive data flow and information system from immigration gate to living community to offer home quarantine people for health declaration, civil service, and health service and decision support. We realized the time and the virus did not wait for us. We launched the following system in a very short term. First is a quarantine system for entry. On February 16, we launched this online system travelers with smartphone can log in the entry quarantine system by scanning the quick response code while waiting for check-in or landing taxi. Travelers can complete the health declaration online while waiting for their flights or upon entry. The information of health declaration includes name, birth year, identification number, passport number, mobile phone number, health condition, and the traveling history. The notification page for passengers' health declaration received by us will be sent to the passenger's mobile phone by text message when he arrived to airport and walked to the custom gate in Taiwan. After that, the traveler will get faster immigration clearance by showing the notification of health declaration. In brief, traveler can complete the health declaration and get quick immigration clearance with 4 simple steps. Scan the quick response code, fill out the form, get notification page of a health declaration via text message, and show the page on mobile phone to the health office. This system provides travelers to input correct and effective personal contact information over mobile devices, which highly improves the data quality and following severe and health service. The second one is the epidemic prevention tracking system. Along with the quarantine system for entry, we created a management system for severe and health services. We pass the electric information collected from entry quarantine system to different level of severe affairs and health authorities. For village level, the officer can call by telephone or on-site visit to track health condition for people who should be home quarantined and coordinate their living or health necessary and demand. For example, meal supply, garbage disposal, physician visiting, etc. For city or county level, the mayor or city government can monitor the total quarantine situation and plan the resources allocation. The policy, the police department also gets the information automatically for offer necessary assistance to severe and health service officers. We extended this system service from home quarantine to group quarantine and dorm of foreign students. It assists the 14-day quarantine policy work and implemented. The Central Epidemic Command Center hold all real-time data and confirm all standard procedures are solidly acted. At the same time, mobile phone number can be used not only for case contact, but also for carrying out home quarantine. The third application is the electronic fence system. We cooperate with mobile phone service corporation to understand the home quarantine people whether stay home or violate the rule. In case the rule is violated, the system will send a text message to notice and remind the case should go back home as soon as possible. If the case still does not follow the alarm notice, the system instantly sends an instruction to policemen. Policemen will visit the guy. This technology is a phone-based application that uses location tracking to ensure people who are quarantined stay in their designated location and allow the authorities when home quarantined individuals leave their designated location or turn off their mobile devices. Another application is robot system. Moreover, on April 1st, in order to reduce the working load for daily tracking home quarantine case by phone call or on-site visit, we also team up Taiwanese electronic brand HTC Corporation and the most popular social media app, AeHIN, to create a fully automatic online platform that allows people in home quarantine to submit reports or requests for their health and living condition and obtain health knowledge through the boat. The boat also offers free amusement, including music and video stream service. We initiated a user certification survey at May. The full score is 10. No matter the severe service over the boat, the score is higher than 8.5. I'm proud of this result. It's the data flow as I show you. Most IT applications I introduced today have services for more than 8 months and almost are modified and upgraded every day at further 3 months. The amount of data exchange over users is listed for your reference. But the population number Taiwan is a wrong number. I'm sorry. The real number is 23 million. 23 million, not the 2.3 million. It's 23 million. I'm sorry for the fault. We summarize our strategy and experiences to 2 websites in English for international friends, as shown in the final slide. It's my pleasure to attend this meeting and share with you. Thank you. Thank you very much.
Merci beaucoup, docteur.
Thank you very much, Dr. Pang, for this presentation, which was quite impressive, very impressive in the things that you did in Taiwan and the results that you got. So thank you very much for sharing that. So this is yet again another example. We had example from Africa, an example from Asia. So we are very remote, but we also share a number of joint concerns. Now we're going to take the different questions for Samia, Julie, but also Dr. Pang. So there's a first question here on my tablet, maybe for Samia. They say, hello, I have a question on your study. How is it possible that in so-called developed countries, technological solutions was not able to stop the pandemic? Answer, well, there's a debate at the level of the European level at large, and not only in France. There were many efforts that were undertaken. There were a number of analyses that were conducted in e-health. We focused very much on Africa and countries from the south, but I think that the physical infrastructures, we were lacking those physical infrastructures in Africa, and for this reason devices like smartphones or mobile phones became all the more important, and this explains the very good results that we got and the good adoption rate that we have, because obviously we focus on COVID crisis today, but there are other areas in which those devices are very interesting, for example, in the fight against malaria or in the prevention of infant mortality. In Africa, more often than not, a computer or a mobile phone is the only way for you to get in contact with a medical professional. You know that in those countries, it's 1 day worth of travel to a hospital or a healthcare provider. It's difficult to also access hydroalcoholic gel. So really those applications in Africa are a lifeline, and they are the only way to connect to healthcare providers. So my answer to the question will be the following. The reason why there is a gap between the use of those technologies in countries of the South and the adoption that we have in so-called developed countries, it's just that there are no alternatives in Africa or countries of the South. A mobile phone is the only tool which make it possible to have screening or to access healthcare professionals. For example, in Kenya, the application that we talked about is a free of charge application. It's supported by a startup, and they equip a number of community-based providers in Kenya. And again, most of the time, those smartphones become a lifeline. It helps with access to healthcare, especially for people with a less privileged background. We don't need that type of infrastructure in France because we have so many other options. And so it's quite paradoxical, but this is why I explain, and this is how I explain that there was a lot less adoption. And this is also why I explain that technology, mobile phones, in medical deserts in southern countries, it is really a question of life and death. And this is why there is so much adoption and potentially less adoption in the north, because in the north we have other options. We do not need those lifelines, and I think this is why we do not have a one-size-fits-all solution. I have a question for Dr. Ming Pang in Taiwan. We see that the system that you implemented was very efficient, and it was thanks to digital equipments, thanks to mobile phones, and I suppose mostly smartphones. So does it mean that 100% of the Taiwanese population has a smartphone? Don't you think that maybe some people were excluded from your system? Do you think it's the best way to communicate with population?
Yes, in Taiwan, the number of mobile phones is more than our population number. But for somebody just like a very young kid and very old people, maybe they cannot use mobile phone. So in the system, we connect with their family member. Even the kids don't have the mobile phone, but their family member can have the mobile phone. So we connect their family member to keep them away from violate the home quarantine rule. Another very important infrastructure is the national health insurance. In Taiwan, even very young kids, they have the smart card of health insurance, so they can use their smart card by their family member to purchase the mask. So everyone can very easily get the mask.
On va avoir aussi bien sûr un micro qui doit circuler dans la.
A microphone will also be circulating in the room here in Lavaux if you want to ask questions to Dr. Pang or to the other speakers. There's another question for you, Dr. Pang. your system is also based on data collection, so massive data collection, also a follow-up and also tracking of individuals. Is it well accepted by the population, the fact that so many data are collected?
Yes, we have to follow the privacy law. So the data we collect only can use, for example, maybe 28 day or 14 days, and after the day 9 should be deleted. So we should follow the law. Yeah.
J'ai envie de poser la même question à Julie et puis.
I also have this question for Julie and Samir. There will be a discussion today. So we talk about e-health being a way to access health services, but we see that today e-health is not only access to health, but also data collection and how we're going to leverage this data. We do see with Dr. Pong that countries like Taiwan have an infrastructure to do so, but society is also ready for that. Now, of course, we need to have a legal framework to really frame the use of this data. So what would you be your point of view? Because this is a question that is still a hurdle in northern countries. So what would be your take on that? Yeah, we can think about the Stop COVID app that we have in France, which was not widely downloaded by French citizens because there was no acceptation by the French population. Well, I do see also the experience that we've had so far. Systematically, this is a question that comes in the forefront. How citizens are very concerned about the safety of the data. They want the data to be encrypted from end to end. They want to be sure that the data remain anonymous. They want to make sure that the data are safeguarded and protected. So it's true that those are health-related data. They are pretty sensitive by nature. And this is true that this is a question that we keep hearing when we go at grassroots level. And most of the time, we do have an approval from the state, but we have a hard time with our populations. And it's also questions that we have in Africa. Obviously, we need to have a strong partnership with between the population and the government, and we need to have this reassurance. And we see a number of projects, not only during the COVID crisis, but when we try to, for example, to prevent infant deaths. We have a number of projects in this area as well. The first step, if we want to boost such projects, is to have partnerships with communities or partnership with local authorities. Again, every time we want to have a follow-up and every time we want to collect information, we need to be backed by the government. So we first need to be supported by this, and then we can scale up our solutions. Maybe there are questions in the room, says the moderator. Can you please introduce yourself before you ask your questions? So as I explained, for health reasons, you can't take the microphone in your hand. I have a question for Taiwan. I'm going to ask this question in English.
Question for you. Thank you very much for your intervention on what happened in Taiwan. I was intrigued when I saw the information flow on your slide. Interoperability in your health information system is obviously crucial to be able to collect all this information and analyze it in real time. I'm curious, in Taiwan, this is a major challenge for most countries. You know, this is foundational and part of a national digital health strategy. How long did it take Taiwan to be able to get all of this foundation of interoperability between all of this information flow you described? And what sort of investments was needed for this? Thank you.
Merci. On va poser tout de suite la question au Dr Ming Pang et j'en rajoute une qui nous arrive de la part des internautes.
So this question, I hope, was heard by you, Professor Pang. So we would like to know how you work, maybe in between ministries, to help with data circulation.
For home quarantine, and it's regulated by the privacy law. And we should summarize our data utility report to our parliament. So it's under legislative department control.
Pour compléter, docteur, pardon. Pour compléter, docteur.
To add on to that, you said that you have a cloud-based system, which seems to be at the center. Is this cloud hosted in Taiwan, or did you use international clouds like Azure from Microsoft, for example? So where is your cloud hosted?
No, only in all data centers, yes.
Donc juste des data centers locaux.
So you have local data centers, is that right?
We have Taiwan's data center in center of the center. Our data center is in CDC. So.
Une toute dernière question, peut-être de la salle.
Last question from the room. I do see a show of hands. This will be the last question for this roundtable. Before we talk about the award winners, the gentleman here would like to ask a question. Thank you. Thank you very much. I have a question. I'm Dr. Drago from Burkina Faso. I really liked the presentation from Taiwan. There was a question about the data privacy, and I was very happy with the answer. Now, when I look at the workflow from Taiwan for entry on the territory, there was a QR code that needed to be scanned before the person received a text message. I wanted to know whether this was an Android-based system or whether it could be used with other platforms.
Dr. Ming Pang.
So the question was whether it was Android-based. Dr. Pang was, how did you manage from a technical point of view? Was it an Android-based platform? How was it only available on Android smartphones or all types of smartphones?
Our system is platform independent. Yes. It's a web application, not an app.
Donc on est.
We have studied if we apply to app, should be upload to iOS or Android, and the review date for upload is too long for us. So in the early time, our application is modified every day. So as I have presented, so we upload our system for platform independent, and it's a web application. Your mobile phone or computer have a browser can use our system.
Merci beaucoup, Dr Ming-Pang, pour cette réponse.
Thank you very much, Dr. Pang. Thank you very much. Congratulations to all of you. Thank you for those examples, very concrete. Thank you ever so much. Now we're going to continue with the next point on the agenda, which is the presentation of award winners for the 2020 installment of this
Et l'on part tout cela tout de suite pour 5.
So we will now travel to Singapore with Edouard Bouty, who's the founder and executive CEO of Reach 52. So we really have international people. So thank you, Edouard. What time is it in Singapore and what's the weather like?
Very much, and very much ashamed that we can't all be together today. But yeah, hello from Singapore. It is 5:30 p.m. here today, and I actually can't see what the weather's like. I assume hot. It's always very, very hot here.
Merci pour ce rayon de soleil du Sud, Edouard.
Thank you, Edouard. You are British. You are now living in Singapore. You have developed Reach 52 for the most remote populations from hospitals. So you are the first nominee award winner of the eHealth. So how does this project work? Let's discover this in video.
52% of our world cannot access healthcare. That is 3.7 billion people that need access to essential healthcare. And we look to build low-cost digital models to serve them. We train women in rural communities. We give them a phone and we give them a salary. Through our training, they can become like a health worker. So it's a community-owned, community-run network of women in villages that provide essential health support. So when we launch in community, our network of women access managers on the ground go door to door and collect data from every resident in the village. Based on this data, we work with the government and we design outreach programs from door-to-door events to group events to rural clinics to connect local villages to the care that they need. So for us, success is about connecting people to essential health services from both government and private sector. We want to create a sustainable model where we really work with government to support them. So when we receive the prize, we will continue to invest in our technology. We've already built a robust platform to support community members, and we want to enhance this further, growing our users and growing the amount of services that we can offer in these disconnected areas where traditional health services don't reach.
Voilà, Reach 52, premier lauréat.
So, Reach 52, warm applause to this project. So, Edouard Bouty, are you here with us? So, first question, and maybe it's in the project that you have presented to create a closer bridge. So, why did you involve women in the project?
Yeah, that's a really great question, and yeah, hope you enjoyed that video as well. And again, thanks for the ODS team and everybody involved for helping us pull that together. Yeah, going back, I mean, yeah, to the start of Reach 52, we, as mentioned, we look to really connect rural, underserved communities to healthcare. We work in about 1,000 communities across the Philippines, Cambodia, and India. And the first idea actually was just purely an app, you know, just the tech for people to access healthcare. So we were going to these rural villages. We were actually getting a 10-inch Android tablet and putting it in a common place, you know, by the church or in the center of a village, and just expecting people to be able to access healthcare using a technology platform available in a shared location in their rural area, and then they could order their medicines and speak to a doctor through that. And yeah, very, very openly, that didn't work really. People just weren't self-serving. They weren't necessarily, well educated about what healthcare they needed. And that's where we evolved our model. So we started finding out the local people that were actually trusted for healthcare advice and where people, in the absence of doctors, often went to for healthcare advice. And we empowered them and we changed our model a bit. So why women? Often just because they are the source of healthcare information and support where there's low to no doctors. They're often trusted by communities. They often don't fit into the local labour economy because a lot of the communities we work in are farming and fishing, which tends to be male-dominated industries. And, it's just great for us because we've created 400 jobs this year. So we create employment, also, leverage these trust networks and really allows us to deliver an impactful service.
Et est-ce que le fait que ces femmes n'aient pas de
because they are not real doctors, they're not nurses, they don't have any education, is that a barrier for you, for your application?
Yeah, it's a valid point, and just to be very clear, we do not replace doctors or nurses with these women that we hire and train. You can sort of think of them as coordinators, village level coordinators. So imagine you're in a village, 3 hours away from a hospital. We train 1 or 2 women in your village. They might go to your house and ask you about your healthcare needs, really collecting data and so on. And then we're working with the government primary care provider, so with the government, with the doctors, with the nurses. And based on that data, we organise a range of programmes. So that can be diabetes screening events, or it can be rural clinics, so we've done work in hepatitis and HIV screening. And what would happen there is the government would go and run a one-off clinic in the community. So they'd be bringing a nurse, doing the screening and stuff. And the people in your village would just be knocking on your door, they'd be getting you out of the house, they'd be making sure you're in the right place at the right time, and then obviously also ordering the medicine that you might need, delivering that back, helping you order discounted insurance as well. So I guess they're really more sort of facilitators or navigators of care in the community. And they really just look to work in partnership with the government healthcare providers to bring them to the community and then play a facilitating role in making sure that community is in the right place at the right time, I guess.
Edouard Bouty, vous nous rappelez à juste titre.
Edouard, you were saying that you were working with the governments hand in hand. Can you tell us very briefly what you do? What is your business model? In other words, what is the economic model, if you like? Do you have something specific for you, for your project? Are you paid for all your action?
It's a really great question, and we're fully transparent about how we make money. So I guess to the first part of the question, yes, 100% government are fully involved in every country. We have formal memorandums of understanding in terms of our work with government, and if there's a government service available, we always use that first and really look to bring existing government services that are often in the middle of the town. We just look to work in the villages around the town and really help decentralize and bring government services to those communities. But obviously, just through this network of women, we're also ordering discounted medicines and insurance plans from private sector partners. So in most of our sites, there's very little government coverage, and therefore we have to work with private sector to bring in more affordable medicines and stuff to the village because the government simply doesn't provide it. So in terms of our business model, partly it's grants. So we do get grants. We have received a number of grants this year from donors and large private foundations, and of course ODS and so on. I'm very grateful for that. But then secondly, we also do sell discounted medicine. and we make a small delivery fee on that. So often the travel to the nearest town might be $4 or $5 for the bus. We charge about a $1 delivery fee, and we bring discounted medicine to the village. And that gives us a small revenue channel as well that allows us to pay the women and keep the model sustainable.
Toute dernière question, Edouard.
One last question, Edward. You have developed also this application to fight against epidemics, and COVID is what we're talking about right now. How about hepatitis B also? Can you tell us a little how you've adapted your application to these two problems?
Yeah, it's a really valid point. So yeah, if you think about our core technology, we can collect data on healthcare needs, run these health events, sign up attendees, book appointments with local facilities, do public health campaigns and manage one-on-one interventions, order medicines and scan prescriptions, order insurance, deliver medicines. So really sort of spanning the whole patient journey. To integrate the patients, though, the citizens, we use a lot of Messenger. So say it's reordering your medicine, you might do that via Facebook Messenger or via SMS, because people tend to use those applications anyway. So I might be your health worker. I invite you to the event, you get a screening from the government, you order medicine from me, you pay me as your health worker, I then deliver it to you. Then the next month you get an SMS or a WhatsApp message or whatever. Do you want to reorder? Yes. And then that places an order in our system, and then I would just get the order as the health worker and come and deliver again. So yeah, with COVID, of course, hugely problematic. We've been doing a huge amount, firstly on letting NGOs use our apps. So we've started working with 6 NGOs in our core countries to help them give access to more products and services. And then given that we do a lot with Facebook Messenger and WhatsApp, we built COVID symptom checkers and where to get information and where to get support within Facebook Messenger. And then we ran Facebook ads that were paid for by Facebook to promote this. So, if you're worried about COVID, you see an ad on Facebook, click the link, Facebook Messenger pops up, and then you can really just chat. It just feels like you're chatting to a normal person, but it's actually technology that's replying and it's just automated. And then we were giving COVID advice, managing referrals, checking symptoms, all through social media effectively. And we've scaled that to about 1 million people now, funded by a grant from a major global organization, as well as using it to support health workers as well. So we were actually giving this tool to frontline health workers. So as they were finding patients, they could also know what to do and get advice, but really using social media, because of course that can still get into communities where often physical movement is quite limited given the lockdowns.
Merci beaucoup. Merci.
Thank you so much, Edouard. Thank you for all this information. And we can see through your Reach 52, you have challenges, of course, but now we have more information given to the remote population, but also data collection for each patient, analysis of data. But on top of this, you have a valuable brick, that is to say social networks. Now, these are GAFAs, but this is maybe a good way of keeping in touch with populations, because you talked about Facebook, how GAFA can really help us. Thank you so much, Edward. Warm applause for this wonderful project. Congratulations, Edward, for this award. Stay with us. I'm sure that we will have a lot of comments, questions on Reach 52. Don't hesitate. We already have a lot of questions coming through our chat. One quick hello to from Bloomshire, who is working on the eHealth network, and says also congratulations to all the award winners. Reach 52, thank you, and hello from Thailand. Jai also, who is also correspondent in Cayenne, also in Asia. A quick hello, Jan. Sorry, he's in India, and he's saying congratulations for this wonderful meeting. Now we will switch from Asia to Africa and meet our second award winner. and nominee. We are going to Togo, Lomé. We will have Rodrigue Kafui Kofi Akoli. So hello, Rodrigue, can you hear us from Togo? So please switch on your mic because we cannot hear you. We can see you, but we cannot hear you. Hello, Rodrigue, can you hear us? In Loma, it is 9 o'clock. And do you have sunshine? Do you have heat? Is it warm and sunny? Yes, we do. So thank you. Send us some sunshine. You are the executive manager of e-Centre Convivial. All the questions around sex. So how does it work on e-Centre Convivial? We'll have a small video. Hello, this is an application which is 100% confidential, anonymous, and it's an opportunity to get information on sexual health. The main action that we do is to work with schools and also manage sexually transmitted diseases. And we also have to scale the e-Centre Convivial with the new technologies. We also have a wider technical plateau. We work with a lot of people that are going to help these young and answer their questions. Okay, the e-Centre Convivial in Lomé, second award winner of this year, this 2020 prize. We are very digital for young people. It's easier for them to get information via app, through a phone or a computer. Now, why? You are available 7 days a week, 24 hours a day. You can ask your question at any time. Is it because you have a generation that are very impatient? They need to have the information not right now? Now, this subject, and in Togo, it's very difficult to have appointments or information to inform. So unfortunately, even in schools, they don't have the right information. It's difficult. So what we want to do is to make sure that we can give them some information. It's a concern by young people, but also pregnant women. We have decided to have an app, and to make sure that this app gives information anytime, anywhere. And we wanted to follow the internet wave. Yes, it's important, and we have heard this a lot this morning, bringing the right information, the proper information, adapted information. On internet, we find things that are not necessarily true. Is that the case? Information? Yes. We want to give reliable information. Health professionals give that information. And so people who go on the application, they know that they're going to get reliable information from a health professional. They want to find information on specific topics. You are managing an e-Centre Convivial, so the other actions of this e-Centre is digital. And also attracting young population, but you also have a physical brick-and-mortar centers where you have nurses and doctors. Is that the case? Yes, this is one application. But there's also the possibility of having online consultations. And we still want to welcome people in a center. So, sometimes we need to welcome these people. They want confidentiality. And we want to make sure that we ensure this confidentiality by having centers. And again, the information has to be safe. And the service provider is here to really work with these patients. And patients feel safe. The idea is to be as close as possible to the patients. So then we have a follow-up. And then we also give training. The idea is to have high quality medical service. Again, when we call the e-center convivial, we know that the data is going to be protected. And it's safe for the user and the service provider. Togo also had a COVID epidemics. You had some curfew imposed. And so, of course, people had to use digital tools. Did this have consequences on the questions that were asked to your e-center? What kind of messages? People were afraid? People were concerned? What happened during that curfew period? Now, when we first knew about the COVID case, we have decided again to have curfew. So e-center convivial was perfectly adapted to this situation. Because overall you had now e-health consultations. And that was necessary, especially if people stayed at home. So we decided to increase the number of online consultations. So we also had to train the doctors. We also had to communicate to the population. We had to inform the population about what we could do. And also to environments, we had to adapt ourselves to technology. We did not feel that it was difficult. We didn't see more people, more concern. Obviously, they were able to use the application and they felt reassured. Thank you so much. So this is very useful, especially during lockdown. Very quickly, Rodrigue, do you think that this e-santé, e-center convivial can be duplicated? Or it's so specific to Togo? Can you duplicate this? Is it a model that everyone can have? Yes, we believe that it's can be duplicated. The idea is to keep a social link and also keep a link with the population, whether it's in Togo or in another country. Again, the population has to accept. And today, e-center convivial is part of the tech solutions for health. So today, we're already thinking of expanding and duplicating what we did. Maybe in other countries, regardless of the situation. Well, thank you, congratulations, and this is you deserve a warm applause for your action. So again, 24 hours a day, 7 days a week, young people in Togo can ask questions through e-center convivial. So I'm sure we will have questions from the room or also the chat. So a first question for Edward, if you're still with us, Edward, does your application also covers mother and baby health. That's a question for Edward.
Oh, sorry, I was just coming off mute. Did we cover mother and baby health? Yes. I mean, we tend to focus on three main healthcare areas. We've maternal and child health has certainly been one of them. We had a couple of slides for this presentation, and that was really actually looking at what we've done in this space. We've done a lot of scans and screening for pregnant mothers. We've done vitamin distribution. We've done antenatal and prenatal care checking with midwives. We're currently doing a program with Philips on ultrasounds for pregnant mothers in rural areas. So yeah, it's one of our top three focus areas. We've also worked in infectious disease, specifically hepatitis and HIV, as well as non-communicable diseases like diabetes and hypertension as well. But yeah, maternal and child health has been a top one for us, and where we've seen a huge amount of progress as well. Thanks for the question.
Merci Edouard pour cette réponse. Je regarde
Thank you for your answer. I'm looking to see if in the room we have people who want to ask questions. If yes, we'll give the person the mic. So do not touch the mic. Sorry, someone will keep it for you. I have a question. Listening to all these projects, very interesting. Thank you. We provide information, and in Togo said that I'm bringing real information, reliable information, and I find that one current problem that we have is fake news. The scientific articles up to now were published and discussed by experts. But there was what we call a retention of information, and that posed a problem. Now, with sorry, there was a problem with the sound. There was a problem with the sound. So we decided to publish on what we call pre-publication platform, so that information was quick, but it's not a validated information. So therefore, you have a risk. You have people who are not necessarily doctors that are going to disseminate this information. As a result, you have a lack of reliability, and people don't trust experts anymore. So how do you orchestrate all that? That's the question. Thank you. I will maybe ask Rodrigue, because they answer questions from young people with reliable information. So basically, where do you get this information? How do you train also your workers to make sure that they give reliable information and not fake news? We have a partnership with the government and the Ministry of Health. They also give us information, and they train us. It's not information that we get from social network. So this is reliable, validated information that we get. And there's a specific medical team in Togo working on that. So it's a coordination that we have, and that's how we communicate. So we know that the information is safe. It's updated on a day-to-day basis. So right from the beginning, these are doctors, nurses, health professionals that give the information, and then they train also other caregivers, making sure that the information that is given is reliable. So again, we don't want to be a victim of fake news. We don't want, but it's true, people call us and say, we heard this. Okay, so training of trainers or trainers of training. So this is really important. Thank you, Rodrigue. Thank you, both of you, Edouard and Rodrigue. So congratulations to our first two award winners. So we see very concretely how digital tools bring people closer. In a world that is disturbed, it's good to spend a couple of minutes to take a step back, to look at things from a historical point of view. For the past 20, 10, or 5 years, how the digital tools have been integrated and shaped the national strategies to fight against epidemics. Asia, Africa, and now also in Europe, because I think we're all faced with the COVID. That is the topic of our first panel discussion, and you will see very concrete examples too.
Et nous a donc rejoint sur ce panel.
So I'm joined here on stage by Dr. Bukari Ouedraogo. He's the director for Health Information Systems from the Ministry of Health in Burkina Faso. Thank you for traveling all the way from Burkina Faso. You are you're a very frequent partner to this meeting. We also have Derek Minini, Head of UNAID Capacity Building and Collaboration from the World Health Organization, so directly from Geneva. Can you hear us loud and clear?
Écoutez, le son est parfait, l'image est parfaite. Merci d'être avec nous.
Yes, very well. The sound is clear, the picture is clear as well. I know that the rules from the World Health Organization are such that you cannot travel from Switzerland. But we also have, from Switzerland, Hani Eskandar is the Senior Coordinator Digital Services at the International Telecommunication Union. I'm sorry, which is the union for the United Nations. Mr. Eskandar, can you hear properly from Geneva this morning?
Yes, I can hear you perfectly. I hope you can hear me as well.
Écoutez, c'est extrêmement parfait.
Yes, that's very clear. So you can decide to speak either French or English. I know that you speak a very good French, also because you live in Geneva. So you can decide to speak in the language of your choice. Now, this panel discussion has to do with the impact of digital tools in case of pandemics. So with the COVID-19 crisis, we did see quite a booming in the use of those technologies. This is something new, right? Mr. Eskandar, you are at the forefront when it comes to the use of such applications, and I'm sure that you saw some extreme examples. For example, in Korea on the one hand, and Sierra Leone on the other end of a spectrum. So one country with a number of resources and one with less resources. So what were the differences in between those countries? Yeah, so you are a privileged observer of those digital solutions, because this is the heart of your work. Can you cite examples of countries that have adopted such tools? When we were preparing the panel, you talked about two countries that are very much opposed, Korea on the one hand and Sierra Leone, yet both had very good strategies with digital tools. Could you tell us more about those two countries?
Thank you very much, and thank you for inviting me to be part of this panel. Indeed, actually, what was very interesting that countries really leverage digital in very different manners, but with the same objective, is how to inform the population, how to get quicker and better diagnosis, etc. What was interesting in both cases I mentioned, like Sierra Leone and Korea, which are very different in terms of their maturity of the infrastructure and connectivity, etc., that they managed to reach scale. And this is one of the things that is extremely important when we talk about any of the use of digital health, because we have seen a lot of excellent pilots and excellent experiences and very successful, but they remain at relatively low scale. So in Sierra Leone, what was extremely interesting is they leverage the basic mobile channel, which is SMS and USSD, and they used the government service that was already there before the COVID to launch this service. So it's very basic, but it's extremely useful and extremely impactful as well. So anyone with even a basic mobile phone, you don't have to have internet. You can whether write to a question to the SMS 468. You can just send a keyword like check or symptoms or temps or updates, and then immediately the system will react and send you information. And you can do the same with USSD. The good things about those simple tools is that, one, they reach the population immediately. It's scalable from day one. It costs zero for the end user, but also it's very much customizable to cater to the different needs. So here, what we saw in Sierra Leone, that they have done, for example, a simple self-checker and a symptom checker. They were sending tips and updates and information to combat infodemic. They were using the local languages. Then they were also catering to the local context, and more importantly, that they have leveraged an already existing infrastructure that was already there as part of the government public information system. So that was quite a successful model, and we have seen some countries have done something similar, like in Niger, for example, where they used similar system, but they sent voice messages. It's an IVR where you call and you get the message in your own local language, which is another very important issue to make sure that everyone will get the information for free and scalable. So for me, this was a very good, because it's easy to use and scalable at the same time. On the other side, on the Korea, actually they have a completely different set of usage, but as efficient as with the case in Sierra Leone. We probably all know they have leveraged a lot things related to contact tracing, for example, but also they used a lot the advanced tools in terms of telemedicine and in terms of AI-based solutions to early diagnosis of COVID through the analysis of X-rays, images, etc., which was accelerated and make early diagnosis for COVID cases. And also they have done a lot of types of applications to really break the chain of transmission. And they also had a lot of data that they can leverage through AI. Both countries have managed to leverage what they have, but with this same lens is how to reach the whole population at once. And I think this is maybe one of the messages that we can convey today is be ready with public platforms that can reach the population, and then that are easily customizable, that you can create those services very quickly in terms of pandemic, because you don't have a lot of time to build up new solutions.
Extrêmement,
you need to leverage what you have already.
Extrêmement important ce que vous nous dites. Hein.
Yes, this is very important. You have to be ready. You need to have governmental platforms to both have bottom-up information but also top-down information. So the two examples that you cited, Korea, Sierra Leone, two countries that are very different from different points of view. So that was very interesting. Now, Dr. Bukari Wadrogo, you are also very much involved in health information systems. Can you describe very quickly the type of data that you collect and how you harvest information from the whole country in a very quickly and efficient manner? Well, thank you very much. Again, I'm going to concur and say that it's a pleasure to be here, and I would like to thank the Pierre Fabre Foundation for organizing this conference. Now, in Burkina Faso, since 2013, we have an experience in collecting data routinely. So we have health-related data that are collected, and we draft a report based on that on a monthly basis. So those data are hosted in a data center in the country. Question: what do you do with this data? Again, in the framework of COVID crisis, but there are also other diseases. So how do you use this data very concretely? Answer: well, those collected data, the previous speaker talked about it, Dr. Eskanda. I really liked what he said about the initiatives in Niger or in Sierra Leone. But when it comes to Burkina Faso, in the last 6 years, we have epidemiological data surveillance. So this is internet-based and also mobile phone-based. We started with a pilot project, and now we have disseminated that. So on a weekly basis, we collect epidemiological data. And this is really a way of which helps in informing the decision-making centrally. So this model, once you have the data that are collected, then pooled, it really helps in informing the health policies related decisions. And we also look at the information that can be useful. I'm going to give a concrete example. So on a weekly basis, for example, if we see many cases of meningitis or many cases of seasonal flu, well, we have this information, and we know that we need to intensify health-related information, for example, or health-related information campaigns. So from a central point of view, it provides a snapshot of the epidemiological situation, and it helps in informing our decisions and our approaches. From a health point of view, centrally, at the central level, we do have an interface through which we follow up very closely on a number of trends in diseases. And so we have that again centralized thanks to this data harvest. We also have an interface which is accessible to the wide population and to get those information. Now on COVID or other pandemics, do you have concrete examples of measures that you implemented, maybe a curfew that you implemented on the basis of this data? So before COVID, we implemented a number of initiatives. We created a platform through which we can collect all information from labs, from biological tests and blood works. And so, as the previous speaker said, it is important to have a central platform to help with diagnosis. And so thanks to that biological database, if you will, we were able to again, we collected data, and we were able to also to place that at the disposal of different citizens. So the citizens or the health, the beneficiaries could also get information based on this aggregated or pooled data. So each player has a dedicated app. So there's an app for the government, but there's also an app for the users. And again, we provide information, but we for prevention as well. And we can also help in screening people, maybe individuals who would benefit from or would need to go to the hospital. So I'm hearing a lot of information in what you're saying. But then again, the question here for this roundtable is to talk about what happened in the past 20 years. So it seems that in your country, you started using those technical tools since 2013 or 2014. origin, as you said. 20 years ago, we were more focused on technology, on devices and not so much on data collection. What you're talking about here is more based on data collection and helps in taking the right and making the right decisions. Don't you think this is a sort of breakthrough? So it's not so much reacting to a pandemic, but rather collecting data in order to prevent, and so to have both a top-down but also a bottom-up data collection. So based on data, also being able to disseminate prevention information. Yes, answer. That is a very interesting comment. Of course, what is key is the quality of information that we collect, the quality of data as well. When someone enters information or data, first they need to input good quality information, but also they need to have trust in the system. And if they have trust in the system, they will provide good quality information. If they don't, if they're concerned about the safety of their data, they won't be providing good quality information. So then again, also users need to be sure that data that is being collected is really used for the announced purpose. So, and they want to be sure that their data is not going to be used for any commercial or other use. Yes, this is very important. Maybe the third step of e-health evolution is again to be patient-centric, more patient-centric, because obviously we need to have those individuals, those patients, they need to be willing to provide information, but in return they want to receive information, and they want to be sure that their data is properly kept. Well, it's true that in Burkina Faso we were rather lucky because at the highest level, and I'm talking here about our president, there was a will to create a ministry in charge of digital economy, and there was a will to provide us with the right digital infrastructure. This was also a serious way to reassure our users and to reassure the users that the data would be used in the right way. Yeah, you do have a data center in Burkina Faso, right? Yes, that's right. The data are hosted nationally in the country, and this is also a massive source of reassurance. We also have a council for health information, and there are two levels. There's a national body, the CIL, and it forbids the use of health-related data if you do not have patient's consent. And also our public health body also makes sure that all health-related data provided by the patient or provided by the healthcare professionals should be hosted in Burkina Faso. So we have this double way to reassure our users and again make sure that the quality of data remains high. Derek Munini, you were born in Zambia. You have a long-standing career in the subject that is of interest for us. So you were a privileged witness in the last 10 or 15 years. Do you think that those tools are really a revolution in the way that we can care for people?
First of all, to thank the previous speakers that have provided the foundation upon which we build e-health or digital health systems, government ownership, and the examples that my colleague, Mr. Hani Ekskand, has given in two countries that is specified. As you rightly mentioned, I have had the rare honor and privilege to see the evolution of digital health for the past 22 years, beginning in Zambia, of course, my native country. And when I reflect back, the past 20 years or so, we've seen a tremendous progress and evolution in the area of e-health, which previously was dominated by telehealth. Specifically in my own country, at the beginning of e-health programs, we early on recognized the need for patient-centered health services via a continuity of care mechanism, putting patients first, as is our motto at the WHO. And quite early enough, we were able to take bold steps to really, put digital within the spectrum of health service provision. And what we did with the team in Zambia there was to really get bold steps around making sure that patients and patient privacies, patient data, patient continuity, including privacy, is actually taken care of, because we really cannot ensure better health outcomes without making sure that we're getting quality data that is both representative of the patient's profile and also is able to follow the patient in the patient path. This is a spirit of patient-centeredness that the previous speaker was talking about. In my own country, we built earlier on a system that was smart card driven. The team in Zambia continues to support that particular system. And back, 20 years ago, using smart card in the healthcare sector as an example of a digital or e-health tool was actually quite new because back then we were very involved around data collection. Right now, of course, we need to be focusing more on other aspects such as connecting the data, standards, enabling, and etc. And so within the particular initiative I'm talking about, one of the key lessons that we learned was the need to empower patients with their own data. And so the smart card-based solution that I'm referring to was one of the key enablers of improving patient care. What we saw there was that patients themselves understood the fact that if they carry their data on a portable device from point to point, the continuity of care would be ensured and also assured. That's a major lesson that we have to keep in mind. The patients themselves must contribute to the solutions that we're building, and they must understand what these solutions mean to them. A particular example I provided as we were speaking was the instance where a patient holding a smart card was waiting for the pharmacist to provide the drugs, an update of the drugs on the patient's smart card. The system was down. The patient was aware that if they left the health facility with their smart cards without the smart card being updated, that particular interaction will not be available at the next visit. The patient was patient enough to wait for the machine to reboot, to provide the smart card to the health provider so that the record can actually walk out of the facility with the patient. So this is really a key point in our endeavor, putting patients first, ensuring that patients are aware of what we're trying to do, and making sure that the patients themselves comply or at least contribute towards the improvement of these e-health solutions. There's many examples, of course, in the African continent that have demonstrated the fact that patients themselves are critical in this spectrum of digital solutions, because normally we forget that the e-health solutions we're producing indeed have a patient-facing mechanism. And so a number of countries have been able to show that with good patient awareness, the systems themselves can have good quality data, completeness of those systems in terms of the data capture, the patient care, including the quality of the algorithms, are enforced when patients are involved in the spectrum of care. So looking back, we were really quite involved back 20 years ago on data collection. But looking forward to where we are right now, I think that patients, health providers get it, that data collection goes without saying, but we have to deal with the issue of connecting the data. making sure that the data is not siloed, making sure that we can add on advanced algorithms such as AI, machine learning, and then use that particular data for predictive analytics. All these good things that frontier technologies give us cannot be achieved if at the backbone, patients themselves are not involved in the care process. Just one more comment before I relinquish this particular space. COVID has taught us a lot of things. We are seeing more and more patient-facing e-health solutions. That has really underscored the fact that we need to ensure that the health seekers, the health beneficiaries, have the appropriate ICT e-health literacy skills.
Excusez-moi, Derek Mounier, c'est...
I'm sorry to interrupt you, Mr. Munini, but there are many information in what you're saying, and it's very interesting. In a nutshell, as you said, you went from telehealth to more e-health. We did understand that it was key to collect good quality data. We do understand that now you are striving to using more artificial intelligence to try and customize healthcare for your users. Now, I would like to ask you two questions. First question, do you think that we are reaching a revolution, a technological revolution, or don't you think that we need a society revolution? So to move from a patient-centric solution to a situation where the patient is more proactive, has a good knowledge of technology as well. So do you think that we are about to witness a technological revolution or more a society technology revolution? And actually, I have a third question. In countries of the South, do you think that you are more advanced compared with countries in the North?
Point of reflection, actually. Very good points, and these are very good questions. Over the years, we definitely have seen a lot of revolutions. We're right now in the fourth industrial revolution from a technology perspective, which is now leading us to the fifth industrial revolution, and sectors such as health are not left behind. But I think it's important to realize, as you alluded to in the question, that these revolutions will always be there. But the society revolution, in terms of the transformation of the people themselves, is highly critical. It's obvious that the evolution of technology will always, take place. But what is critical is for us to ensure that the societies in which these technologies live are better able to be attuned to the evolution that is surrounding them. I'm really speaking about the need for example, ICT literacy. It is extremely critical for us to have an ICT literate population, an ICT literate health workforce, so that they can indeed effectively use these e-health solutions, and especially in the era of universal health coverage. We like to say leave no one behind, but we really must make sure we leave no one offline. And this makes it possible for us to leverage the industrial revolution much more effectively when the health sector, health workforce, together with the people themselves, are indeed literate, both from an ICT perspective and to a digital health perspective. And so that's one of the priority areas. And I want to speak specifically to the modalities in which we achieve this transformation of the society. At WHO, we have released a number of normative standards. An early piece of work that we deployed was the National eHealth Toolkit that we deployed together with the International Telecommunications Union. My colleague, Mr. Hani Xkanda, is familiar with this particular topic. That toolkit includes 7 pillars. One of the pillars is workforce. And that workforce pillar should really be extended towards, equipping the health workforce with the necessary skills to engage with a technological environment, not forgetting the people that they are interacting with. You mentioned 2 points in your question, proactiveness and reactiveness. We are in a time where, given COVID, we are being reactive, making sure that we are responding to the pandemic. And so there are a number of things that are happening. Lots of solutions are being developed. Lots of programs are being put on board. Patients themselves are now more than ever able to interact, digitally with the with the health environment. Now, that's taught us a lot of lessons in as far as making sure that we leave no one behind and that people themselves have the right skills. What we need to ensure is that we sustain this momentum of awareness, we sustain this momentum of the purpose, or shall we say how critical e-health and digital health is for the long term, not just for the near term. And I think as we look back to the state of the globe at this moment, almost every direction we look, whether it's the east, the west, the north, and the south, there is one theme. And the theme is that the new normal now is more virtual, it's more digital. The new normal is extremely virtual. We need to sustain this. Between the north and the south, there is definitely a lot of uptake of solutions right now. In the south, a lot of flexibility in terms of having a number of systems being deployed. But as the colleague from Burkina Faso was mentioning, there's normally within the south the realization that it's always critical that the many systems that come up feed into one national M&D system. That's what our colleague from Burkina Faso was emphasizing. What we see in the north is emphasis around standards, emphasis around using multiple applications as long as standards are in place to ensure interoperability. I think that the South is yet to get to that level. In the South, it is a requirement by ministries that there has to be one aggregation system. That's what Burkina Faso is talking about. Whereas in the North, where there are more matured systems, the key discussions there is around data exchange, interoperability. It's a natural evolution, and I think that the North and the South have more to learn from each other.
Merci Derek Mounet pour cette réponse extrêmement précise et qui marque bien.
Well, thank you very much for this very precise answer. Now, I have a question once again for Hani Eskander, also in Geneva. Very quickly, Mr. Eskander, do you share this point of view, whereby e-health tomorrow, even more than today, the main challenge will be data collection and artificial intelligence to be more proactive? Do you think that's really the avenue that we're going to explore in the future?
Much again, I definitely would agree with previous speakers that while the focus was very much before on data collection and building health information systems, I think we are moving now towards how we use these types of data, how we make the better decisions based on the data. But also I think, and it's becoming very much obvious out of COVID, is that given that we need to have a more patient-centric type of services, we believe now that the boom will also happen for telemedicine and telehealth. When telemedicine started, maybe as the first type of e-health, even it was there before there was something called e-health. Telemedicine was the start. However, at that point, maybe in the 90s, it was still very expensive. The equipment were very expensive. It was required a lot of heavy investment and a lot of expertise, etc. And then we moved to more of data collection and building information systems, etc. And I think now there will be a kind of comeback to the telemedicine because of COVID and because of this need to provide to the end user concrete citizen-centric and patient-centric type of services for improving access to quality care, but also for self-empowerment and self-management. However, I think there will be kind of an amalgamation of different types of technologies. Definitely AI will be part of the at the heart of this, because AI will play a huge role in telemedicine and in remote consultation and remote diagnosis and all those kinds of applications. But I think we need to, there is an emerging need to look at telemedicine in a slightly different manner. And to see what are the appropriate technologies that we can use today that are also scalable quickly. And I think in some of the previous presentation today, we have seen, sort of increased use of AI chatbots on social media. And I think this is one of the areas where it will see a lot of uptake in the near future. Because social media is everywhere, people use it, people know how to leverage it. If you marry the AI with it in terms of natural language processing, etc., and you create chatbots that can deliver remote consultation, because currently the chatbots are mainly used for getting access to tips and information, etc. It has been used on light manner on some sort of interacting with the medical professionals. I think in the future we're going to see much more of that, and also better uptake in different local languages, because if you would like to use those chatbots, you need to make sure that they are working well with local languages as well.
Agnès
So
Kandar,
I think those
Agnès Kandar, s'il vous plaît.
kind of
Annie, sorry, please.
is how with use affordable technologies that are already used in the hands of everyone, and really be able to leverage them for healthcare. And what is interesting, I think you mentioned this, are we looking at technology revolution or societal revolution? I think it's both. What is interesting now that the push is not coming from the supply side, from the providers of those solutions, because people are now asking for those types of services, because they are so much used now to use those types of tools, and they are now willing and open and even asking to use more and more of those types of technology.
Agnès Kandar, je vous coupe.
Sorry, I'm interrupted you. Annie, sorry. He cannot hear you.
We need to see how to be ready for that. And I think there is part on the government, but also there is part on the private sector and private providers.
Agnès Kandar, est-ce que vous m'entendez si je vous parle?
Will play its role, then we will have difficulty in leveraging all those new technologies.
Il a coupé son micro.
The part of the government, actually, the government needs to set the foundations. Maybe the government don't need necessarily to innovate themselves, but they need to set the foundations in terms of connectivity, how they can bring connectivity to all the health centers, for example, in a country. And that's very important. And even, I would say now, given COVID, it's a must.
Agnès Kandar, est-ce que vous m'entendez si je vous parle?
Of how you partner with the private sector, with the telecom operator, but also with the other sectors. Because when you connect a school, for example, you can connect also the health center. So it requires even discussion beyond the health sector, how we bring the connectivity to those remote areas. And also how you make sure that there are some basic components already. I think Derek mentioned the smart card, which is a digital identity. Identification is now one of the core components, and there are few elements like that, like registries, for example, electronic health records, and information exchange. Those are core foundational building blocks.
Agnès Kandar, est-ce que vous m'entendez? Est-ce qu'il faut qu'on lui dise de m'entendre, parce que la question qu'il dit, alors on va lui envoyer un petit message à Agnès Kandar.
And we should encourage, the local ecosystem to innovate, but they cannot innovate in building back-end systems because those are extremely heavy investments. So I think the whole issue is how you build up this balance between what the public should do, what the private should do, and how you create this sort of public-private partnership.
On va lui envoyer un petit message pour être sûr qu'il nous entende. Je vous pose quand même la question en attendant.
Okay, so we will have with I think what Annie Iskandar has done and has said is really essential, because that's also what COVID revealed. Now, if you take a step back on e-health, what do we notice is that for 5 years, 10 years, or even 20 years, the players of health were creating their own tools, their own application. They were, I would say, in their own little e-health planet. And we also saw that these tools were extremely powerful, having a broader reach, recognition, AI, language recognition, and what is it? It's GAFA, Facebook, and Google. And what Annie Iskandar has said is, how do you, encourage these players? Can we invite them around table? Can we develop hand in hand with them, knowing that every day they have a reach of millions and millions of people on the planet? And what is your feeling, Dr. Ouedraogo? Thank you. I listened attentively what Mr. Iskandar said, and it's very true. It's important. And I think that it leads us to further thought. Today, we collect so much data, and we have to have a useful data. And for it to be useful, there's a lot of things to be done. We need to maybe have an architect coordinating all that. And so these skills for the countries, developing countries, for the time being, we don't have them. Yes, in Burkina, you built your own data center that is really independent from these big names to have a more trust regarding the population. On the other hand, today, the best researchers in AI are working for GAFA. How you, a country in Burkina, are you going to end up working with them, finding solutions? Well, today we're already working on the subject with Professor, because we have produced quite a lot of information and the contribution. We have a model with AI. And this is the first example that we have. Now, in addition to that, imagine the example of COVID. We have set up a system of tracking everything. Everyone who will consult, do you have symptoms of COVID? So we have a tracking. Every day we can get text messages that comes from 90% of sanitary. So all this has been set up on the tablets. Secure data. So we've not used these data for the time being, but they're important data. And over 25,000 data in just 4 months. So these are personal data, and we need to get the machine talking. And some can do it, to really have packages. And in Burkina, we've not yet used this machine learning and also data processing. The question that has been posed with platforms, because in addition to the data that we are using and also our citizens, that they use this in social data, and you need to have what we call a merging of the data. So yes, today we have new data in terms of health, and the question of collaborating with big players, Facebook, GAFA, how these can be done. How do you integrate this in our health system if we wish to integrate this? So I guess that everything has been said during the roundtable will trigger a lot of questions. A lot of questions are being asked. Now let's just have a quick presentation from another country. We are going to India now. We are going to have Wana Sharma, who has been rewarded for her Kushi Baby project. It is a little necklace that you give to the babies. There's concert. You can collect information, and it's a chip that you have. So we are with India. So thank you Can you tell us a little what this necklace is that you've developed in Cushy Baby? Has it changed during the COVID pandemics?
Hi, Lionel, can you see me?
C'est parfait.
Yes, yes, we can see you.
And can you hear me?
Oui.
Yes.
Mohamed Chanawaz, le projet que vous avez développé, Cushy Baby, est-ce que vous avez fait...
Cushy Baby, have you updated it because of COVID?
So we have converted this crisis into the opportunity. As you know, it's nice to reconnect with the PFA Foundation team here. And it's an honor to be back again and talking to you. So as you know, the Cushy Baby is known for tracking the mother and baby using the digital necklace. And we have a RCH platform where we track the beneficiary right from the family planning stage to the antenatal checkup, then the postnatal checkup, and then the immunization. This is known as the continuum of care. We in the last 1 year, it has been an exciting year for us as we have been selected as the nodal technical partner to the government of Rajasthan, that is India's largest state in terms of area. And then we all set to scale the Udaipur model, where the foundation has been supporting us to scale up across the state. And as a public health expert, we know that the baseline denominator, true baseline denominator is the key. So we all set to conduct the India's largest digital health census in Rajasthan, and that was supposed to be started from April. And then suddenly this COVID happened. And we then use this crisis to convert into opportunity, where we come out with one application called Mission Lisa. Lisa, this life-saving application, where we actually use to screen the people and then refer the people, and then it has to be tracked followed up further by the medical officer. So in the last 3 months, we have been able to track over 12 million people, as you can see on my screen. And we use this as to categorize the patient under different category. And this application that we are using to actually track the vulnerable group, as majority of the population having COVID positive are belonging to this vulnerable group. That includes the pregnant women, the elderly population, and the children. And we are using this data to actually do the early intervention and to actually arrest the further containment of this pandemic situation.
Merci Mohamed pour ces
Thank you for your explanations. Delighted to see you again from India. We know you couldn't travel to France today, but you have been rewarded for your actions last year. And it's nice to see how all this has evolved and how it has adapted to answer also to the situation of the pandemics. Now, before closing this roundtable, do not hesitate to ask your questions around these tools. We have Agnès Kandar online, Annie Eskandar, we have Dr. Ouedrago next to us, and Derek. So we have a lot of questions coming. A question now. When we are having a platform, what is the right scale? Is it good to have public and private sector? What is the right solution? What is the right equation? 100% public, a mix 50-50? Thank you. It's a very nice question. I think the answer, it depends on the environment, the context. Because private, public, if it's private, in the case of Burkina, what happens with private data? If it's public, you need to have individual data. and then maybe cluster all that, pool all this information. But in my country, we're having a kind of framework, especially at ministry level. We have had a lot of vertical actions. We're trying to now have a more horizontal approach so that you concentrate and create a data warehouse for health data. So private, public, it really depends on the legislation and the wish of every country. Annie Iskandar and Derek, maybe some question. First one for Annie Iskandar, Joachim, who's saying, how can we have a non-profit player with such a great number of data linked to data? Is it possible today?
I think this was always the dilemma, is kind of who owns the data and how you manage the data. And what we have seen in many cases that when NGOs and other partners are coming and they are deploying their e-health solution, they have the data, and even the government, they don't know where is the data. Is it in country? Is it outside of the country, etc.? So that's a big thing. That's why I think this comes back to the point I was trying to make, is how to kind of be clear on what are the things that the government needs to do and what are the things that the private sector or NGOs could do. There is a trend now, is this concept of government as a platform. Government as a platform means that the government role is really to provide foundations, is really to make sure that the data is well protected and it sits with clear ownership and stewardship from the government, that some of the core services that are available, maybe through APIs and things like that, to external innovators, who will be really focusing on adding value to the end user without necessarily having to worry about all those kind of things. And the trend now is that to allow and prevent data from going outside of the country before it resides into servers that maybe are in the country or outside of the country. So there are a lot of kind of regulatory and framing of the government that needs to happen. Particularly in countries like in Europe, where there is now the GDPR, where there are strict rules on how you respect privacy, etc. And this really falls into the government role. It is for the government to set all those types of frameworks and make sure to enforce the compliance with those rules, and also making sure that it facilitates innovations. The government role, I always see that their role is not to innovate. The government here is to allow others to innovate, but setting the right rules.
Merci Annie Iskandar aussi de cette position qui est assez précise.
Thank you for your very nice answer. And it's a good idea to think about the future. Another question asked by the chat. How do you envisage a South-South collaboration in digital? Because we strongly depend on northern countries. Is a South-South cooperation possible or not?
Very good point, actually. Very good point. The question of collaboration is an area that we have been working on at WHO quite intimately, because we really cannot see cohesiveness unless we have coordination, collaboration, and actors in the ecosystem of digital health pulling together towards a common agenda. We have an African proverb that says, if you want to go quickly, go alone. If you want to go far, then go together. And so this South-to-South collaboration really sits on this ideology that sort of like predicts that when there is good coordination and collaboration and a conducive environment has been set up, we can actually achieve more together. We are working at WHO on what we're calling a network of networks. There are indeed many networks out there. And so within this framework of putting together these different platforms, we intend to ensure that all the actors that are contributing to this area of e-health are represented, and at the same time they're learning from each other and collaborating quite effectively. We know that when we think about e-health, normally we think about the producers, but there are other actors that are playing key roles, such as the academia, for example, who are responsible towards producing some non-standards qualified personnel that can use the e-health solutions. We also have the private sector, as Hani was articulating, that indeed is at the front seat in terms of innovating, trying out new approaches, and etc. And then we have different actors that are, within the ecosystem of e-health that all need to be coordinated and that all need to collaborate quite effectively. So a number of networks have demonstrated how this is quite effective. AeHIN is one example that has been quite useful in terms of making sure that different actors within the e-health network are contributing quite effectively. In the African continent, we have institutions such as the African Alliance and many more. So collaboration itself, especially e-health, is quite critical. If you listen to Burkina Faso, they talked about verticalization. We can achieve a uniform approach towards e-health. If we are coordinated, then verticalization would actually be minimized.
Merci, Derek Mounet.
Thank you very much for your answer. It's true in the era of the digital and communities working together. Now, very briefly, a very quick answer, more a comment than a question, because we're almost at the end of this. I don't want to prolong the conversation, but I just wanted to say that this morning we spoke a lot about quantitative data. So some questions we have quantity data, and then we add AI. We don't really explain how it comes into play, but there's this also an area of qualitative data. Now, do the methods that we use, are they going to use qualitative data? Dr. Ouedraogo, what do you have to answer? Well, it's an excellent question. I think the qualitative data that we feed, especially in the COVID case, it's mainly data. But of course, quality data is better than quantity data. And that is something that is important. And, I think that we need to push for qualitative data more than quantity, because then if we analyze, obviously we can have bias. Thank you. One last hello to the campus of Vientiane and other countries that are looking and watching us.
Voilà, Vientiane, là, je ne sais pas si on retrouve.
Okay, Antoine, Eric, are you still there? So what did you think of this morning with roundtables, lots of questions? Well, we're very attentive. The connection is not always good, however, but we had a lot of questions from a lot of speakers. Some questions which I believe really have interested the students, medicine. Maybe the question is, will GPs disappear in favor of machines? So they ask question, or the diagnosis tool. Maybe a GP won't exist in the future. I have a doctor right in front of me, so I can ask him the question. Do you think that machines will be replacing chatbots or GPs? Or rather, no, I don't think it's possible. It's going to be extremely difficult, a human being by a machine. I think that one of the, a machine cannot interview a patient. There are very specific questions. The machine will help the doctor, but not replace, for sure. I have no doubt about it. I don't have a crystal ball, but I can almost assure you that no doctor will be replaced. Okay, so you can reassure your students for the time being, they won't be replaced by robots. Thank you so much, Laos campus, being with us. I know it's almost nighttime where you are. So it's the end of this first part of the observatory of the eHealth. So thank you all the participants for the quality and of your presentations this morning. It is 12:50 in Paris time, Europe time. So it's time for a lunch break. We will come back at 2:15 in Paris. Thank you.
s'assoit à la table.
D'accord, attends, je le dis tout. Ouais, on peut pas manger debout, quoi.
Voilà. Tu peux envoyer la sauce dans la salle, s'il te plaît? Hein? Tu peux quoi? Par là?
1, 2, 1, 2, voilà. S'il vous plaît, s'il vous plaît, je ne sais pas si tout le monde m'entend, juste un petit détail, mais qui n'est pas un petit détail technique vis-à-vis des conditions sanitaires. On vous précise que vous ne pouvez pas manger debout aujourd'hui, donc on vous demandera s'il vous plaît de vous asseoir à table et je pense qu'on va venir vous servir dans la foulée. Merci à tous. Ah, on ne sert pas. Ah, il faut aller au buffet. Alors, on me donne pas... Donc il faut aller au buffet, excusez-moi, mais simplement vous asseoir, ça c'est important à table après. Voilà.
Bon, merci. Oui, allez, j'y vais.
Ok, merci.
Très important.
Oui, on est d'accord. Oui, oui, je suis d'accord. Bon, mais bon après-midi, de rien. Quelqu'un spécifiquement à Lomé ou pas?
Non, c'est Nomba.
Je sais pas comment on dit, Nom Baba.
Non, Baba.
Mais sinon, t'es pas obligé de dire son nom. Enfin, dis, je sais même pas. Parce qu'il y a
Bah, j'ai demandé
Rodrigue
qui
est là. Il y a Rodrigue normalement qui fait
Ok.
des coups et tout.
On va voir si c'est Rodrigue qui parle.
Ouais, je sais pas trop qui va parler de l'autre côté.
Faut qu'on y aille là. Fais un appel au micro.
Il n'y a plus personne là quasiment.
Ouais.
Je l'adore.
Je vois que les deux derniers c'est les invités. Un, deux. Ah, le micro est ouvert. Voilà, je vais vous demander de vous installer. On ne va pas tarder à recommencer.
masque. Ah là là.
Bonjour à tous ceux qui nous rejoignent pour cette conférence annuelle de l'Observatoire de la e-santé dans les pays du Sud. Il est 14h23 ici à Lavore en France, près de Toulouse, 19h23 donc à Vientiane au Laos où nous étions en duplex tout à l'heure, 12h23 en temps universel et on poursuit donc nos échanges avec un thème cette année, on ne peut plus d'actualité, les
So there's a new theme for the second part of the meeting. We have a number of connected campuses. They've been very active, asked many questions, and again, a warm round of applause for all those campuses, Brazzaville, in the DRC, in Cameroon, in Kinshasa, as I said already, in Lubumbashi, in Yaoundé, in Conakry, in Guinea, Bamako, Nouakchott as well. They were active on the chat. Niamey in Niger, Dakar. Lomé will have a presentation. Lao as well. They were so successful that they didn't have enough chairs. People in China, in Phnom Penh, in Cambodia. So all those campuses are connected, and also the campus of Lomé, and this is the next country we're going to travel to.
Lomé au Togo.
So Lomé, Togo, can you hear properly? And who are we talking to in Lomé? Yes, we can hear you in Lomé. It's a pleasure once again to be part of this conference. How many participants do you have who came to the meeting? Healthcare providers, persons interested by healthcare, engineers. Who's listening? Well, because of the sanitary measures or the health mitigation measures, we have a few students. We also have midwives and a few members of our staff for telehealth. Yes, and I know that you're paying close attention. You sent many questions. Thank you very much. We will be back with you at the end of the meetings to see whether this conference met your expectations. So again, there are other campuses connected. Thank you also to all the internet users on their smartphones or their tablets. Please do not hesitate to say hello on the chat and maybe share a bit of sunshine because it's not very sunny here. So we're in Africa, we're going to stay in Africa, and I propose that we travel to Dakar in Senegal, from where we're going to have the next presentation.
Dakar, où nous rejoignons Widat Teba.
So Minateba is the regional director of French-speaking countries. Ms. Teba, can you hear? Can you please send some sunshine from Senegal? Well, it would be a pleasure. I'm delighted to be with you. The Pierre Foundation has always been a very dear partner to me, so I'm delighted to be with you during for this meeting. I know that you have a very busy agenda, very busy schedule, so I would like to thank you for participating. And so we're talking about how we can fight against health crisis, and we need to talk also about training. And with AUF, you continued training despite curfew, despite all the mitigation measures that that were implemented in Senegal. Well, you're right. In this sub-region of Western Africa, the question of training is key, and we had to invent measures to continue and train. And so we wanted to transform this health crisis in an opportunity as well. You know that the virtual University of Senegal is a model which is in the process of being duplicated in our neighboring country in the West African sub-region. And so, again, we had a very short time, but we were able to adapt. Can you give us concrete examples of measures that you implemented to further develop digital tools? Answer. Many things were developed. We strengthened the skill set and the expertise of our teams. We also supported, again, the member of our teams, but also our students. We we helped and supported a number of campuses because we thought it was important to provide this continuum of training. As I said, we quite have a cutting edge when it comes to this virtual training that we provide, and so we try to listen to the needs of our members or university members. So you said that you have developed those digital tools when they were not that fashionable. So I suppose that the pandemics really sped up the dissemination of those tools. Will there be a situation before COVID crisis and after COVID crisis? Answer, yes, that's very clear. When you talk with deans and directors, this digital transformation, there was a turning point with the COVID crisis. We entered a new era, and I think that our African universities were bold and brave in the way that they adapted to this crisis. So we have very exceptional examples. There are virtual universities that are the forefront, but they also help other universities to jump on the bandwagon. So you said you talked about resilience, about being bold, about being resilient. Do you think this is a model that could be transferred in Europe, for example? Answer, yes, this is the message that I would like to convey. Of course, the infrastructures are not the same in our area, especially when it comes to network, broadband, etc. But we could find solution, and I think that as you can see during this conference, those tools can really help our students, help our partners, and we have to support them in their endeavor to again mitigate those issues. Mostly in our universities, what we're lacking are mostly infrastructures, because we do have the will and we do have the expertise as well. Yeah, well, thank you very much, Dateba, for your participation to this meeting. Thank you for taking the time to talk from Dakar, and this is certainly very inspirational to hear your experience. Well, again, a huge thank you to the Pierre Fabre Foundation. I know that people very well. We have big projects for Western Africa, but also for Africa as a whole. Beatrice Garrett is sitting opposite me, and she does concur with those plans. Well, thank you very much to you. Now we're going to continue with the conference with one of those highlights, presentation of the 2020 award winners.
Présentation des
So the laureates for this observatory, and we're going to concentrate on one disease, which is trachoma, when a bacteria enters the eye, and it can be responsible for blindness. There are millions of people suffering from trachoma, but this is a curable disease. Now, for it to be cured, it needs to be diagnosed very early on, and also there needs to be a very close-knit follow-up. So Sight Savers has developed a project in Guinea-Conakry, but this project is being disseminated to other countries. Now, Sarah Bartlett is the director for this program. So you're here, you're not in Africa, and you live in France, right? Yes, I do live in France, in the Gers region, not very far away from Toulouse. A very nice region indeed. So, Ms. Bartlett, you're the director of this program, and we're going to discover this project with a short video.
So trachoma programs are incredibly remote environments, and also once we've given surgery for TT, it's required that we do multiple follow-up visits with the patients to make sure that the eyes are healing properly. So these factors combined create a pretty massive data challenge for our programs. So in response, we built the TT tracker, which is helping improve patient care and also data management and use. So the TT tracker is being used in Nigeria, Benin, and Guinea, with Senegal soon to follow. So far, the teams have captured and managed over 22,000 TT patients in the system. We've trained over 150 workers to be able to collect the data, and we've trained over 30 supervisors and administrators to be able to access and analyze and use that data. So countries are able to use the data to track surgical outcomes and plan follow-up activities. It's also a massive benefit to them to be able to have all their data in one place, so they're able to pull reports as needed, including a final report that will be submitted to the WHO in their country's dossier for elimination. We're hugely excited to be able to scale up use of the TT tracker into new locations. So countries where Sight Savers doesn't have programming, but where TT activities are ongoing and where they could really benefit from use of the TT tracker.
TT Tracker, lauréat de...
So TT Tracker is the laureate for 2020. We can say bravo to this project. So you do insist on the two steps for the treatment. There's the surgery first, but then follow-up is very important. I'm going to answer in English because it will be easier for me.
The international guidelines say that after a surgery, we have to do follow-ups at the 7 to 14 day period and a 3 to 6 month period. So that sounds easy, but it really isn't, because the follow-up visits happen in a different location than where the surgeries happen, and they also happen by a different person. So that makes it really important to be able to have all the information on one phone or tablet for them to be able to find the patients who need the follow-ups, where they are and when they need the follow-ups. And also that whoever's doing the follow-up check has all of the information, that full patient record, so they're able to give the best care and advice possible to that patient during that follow-up check. So.
Ouais. Et on voit bien qu'au cœur justement de votre...
And what we see as well, your system is not so much about curing the disease. It doesn't measure, it doesn't do anything specific, but you're collecting data. So what are the data that you collect and what do you do with it?
It's based off of standardized international trachoma forms, so that makes it easy to scale up across multiple locations, because all the forms in every country are the same in the trachoma programs. So there's registration, there's evaluation, there's surgery, and then there's all the different follow-up forms. And so those are used, like I said, by the teams. They're able to see those patient records, which are all connected later, so they're all on the phone. And then they move up. You can see supervisors are able to watch program performance and make changes, clean the data as it's coming in. And then, of course, step up from that, they've got the benefit of having a centralized place where all the data are sitting. It's owned by the Ministry of Health. It's managed by the Ministry of Health. So there's one source for data. And that goes for creating reports of any kind, but it also goes towards the dossier that we talked about in the video. So to prove that the country has eliminated trachoma as a public health problem, you have to fill it in this dossier. And part of it is showing that prevalence is low enough in all the different districts, but another part is proving that you've done certain activities in certain locations. So this CT tracker and having all that data in one place helps them immensely as they get.
Ça veut dire que c'est un système qui fait un double bénéfice.
So there's a double benefit, right? There's a benefit for the patient because we're sure that they're going to benefit from the right follow-up and they're going to be cured from their trachoma. But there's also a benefit in terms of health policies for each country with the objective of eliminating the disease.
Comment est-ce que vous arrivez à coordonner?
So how do you coordinate? Because I understand that you operate in different countries. So are there different policies or do you have a joint policy?
Sightsavers manages this tool, we built it, and our job is to make sure that it functions properly and that people in the countries are using it to the best of their ability. But we do very much see it as a national tool, so the ministries of health are highly involved in making sure that it's rolled out properly and used properly, and again, they own the data. So I think, yeah, a little bit of both.
Vous allez, on l'a bien vu dans la vidéo.
In the video and also in the pictures that are currently on the screen, you also go and monitor people in a remote area. The fact that it's a 100% digital tool, isn't it a hurdle? Isn't there a cultural hurdle here?
But there are definitely different rules to follow when you're trying to collect data or use applications in such remote locations. So there's like the hardware side of it and then the software side of it. So the hardware side of it, it's all obvious stuff, but sometimes we don't think about it. To make sure the phones or the tablets or whatever devices you're using can, withstand lots of dust and lots of sun and many hours without being charged, and all those basic things that are easy to forget. And then on the software side, you have to make sure that any application you're building is accessible offline so that it can be used and data can be uploaded even if there's no connection. And also, I guess, just make sure that this is true for any technology, but they're really building for the user. So if you're building something in a very remote location where people might not have a lot of access otherwise to technology, you need to make it so it's very easy for them to use so they keep engaging. And
Toute dernière question, Sarah, peut-être.
Very last question. Maybe if we want to step back and have another view in the countries of the South, I know that your association also manages other tools and applications. So what is your take on those questions that we contended with this morning? Why do you think countries of the South have more appetite for those tools, while countries in the North do not really develop such tools, do not harvest data in the same way? We're under the impression that there's quite a gap. So you have a more worldwide view. What's your point of view?
C'est pour ça que je la pose.
Yeah, exactly. But I think it might be a little bit of a sensitive one too. I think that a lot of countries in the North, populations are more skeptical of how data is going to be used, potentially, so they're less likely to maybe engage with and give data to input data into these applications, despite the fact that there are regulations in place. And of course, there are regulations in place in the southern countries as well. But I think some of it is around thinking around that. That would be my.
Ouais, c'est le logiciel des populations, mais également le logiciel, j'ai envie de dire.
Well, so it depends on populations, but also sometimes the governance is also skeptical. Do you think it's easier to have those changes in the South? I'm sorry, I didn't understand your question. You said that populations are skeptical vis-à-vis those tools. So you're right, population and tools. But also it can be the system as a whole. Healthcare providers, hospitals, and governments sometimes are skeptical. Do you think it's easier to talk with African doctors?
Especially if you have an application that can help them with their jobs in the end. It's not, because we can't have the focus of just pulling data from programs. We have to have the focus, and people were talking earlier too, of making sure that there's feedback back to the people who are collecting the data and who are doing the work. So at least in our experience, we found that as long as we have that feedback loop, that people, doctors and teams at the lower levels are very interested in using the application because they're getting something from it as well, which makes sense. It's why any of us use technology. So.
Toujours, quel est le bénéfice finalement pour le client?
Yeah, the question is always, again, to have a benefit for the end user. Well, thank you very much, Sarah. I'm sure that there will be many questions at the end of this roundtable. Now we stay on the African continent, but we go to the DRC, and we're going to see a disease which assists in the management of sickle cell disease. So this is a disease which has for a long time been neglected by the PFAB Foundation, has been a major player in this area for years and years. We're going to listen to Arnold Wongbo. He's a founder and director of Genity Salo. So how is the weather like in the DRC? Well, it's a beautiful sunshine. We have a good weather today in the Democratic Republic of the Congo. So you created a startup and you developed an application to help with the daily life of people with sickle cell disease. The app is called AnemiApp. We're going to discover the app.
Une maladie à vie. Donc, on demande des soutiens pour tous.
So it's a lifelong disease which affects the red blood cells, and there's a lack of oxygenation. It is inherited, an inherited disease, and it affects quite a few millions of people worldwide. So Arnold Wongbo is the general director of Genity, a startup. AnemiApp is an app which helps with the management of sickle cell disease. 50,000 children are born with sickle cell disease in the DRC. So thanks to this app, the patient receive information to avoid relapses. So the advices, for example, are to maintain a high level of hydration. Kinshasa has 12 million inhabitants. It's a very large capital city. And the application provides a mapping of the different healthcare providers. So you can identify the places where you can be treated, where you can receive blood transfusions or be delivered with drugs. Today, AnemiApp is supported by the Ministry of Health in the DRC, and it is used by a wealth of healthcare professionals. The objective is to have 100,000 users per year. Thanks to this award, we'll be able to maintain the app, to communicate more, and also to rent new offices. AnemiApp, round of applause, laureate for 2020 for this South Ehealth Observatory. Arnold Wongbo. So before you created the startup, you worked in an NGO, and this is where you first discovered the disease, and you realized that the population didn't have enough information on this disease. So what was it that you wanted to provide in terms of access to information? What was your objective? So, as you mentioned, people here know the disease, but in a very superficial way. So they would make a confusion between the blood type and the blood group as well, and they were not sure how the disease was transmitted. Now, thanks to this application, well, you know that in the DRC almost everybody has a smartphone or a mobile phone, and so we thought that it was the best channel through which we could provide information in terms of prevention and also information. And this is why we came up with that. So this app is used by the wider public, but also by healthcare professionals, because you realized that they were also lacking information. And so you have a dedicated access for healthcare professionals. Why is that? Answer. You know, there are very few experts in sickle cell disease in our country. And so we needed to create a network of those healthcare professionals and healthcare providers. So for example, let's take a general practitioner. They do not have many information on sickle cell disease, and they have a patient coming in their practice. So they can get in direct contact with an expert, and they're going to get recommendations on treatment. So this is very important. More often than not, we want to communicate with the general population, but it is very important also to underline that general practitioners also need information. Not all of them know what is the perfect or the best treatment. They do not know where you can locate the experts or the drugs, so you create a connection in between those professionals, right? Answer, yes. And so with the support of the health ministry, in the framework of a national program of fight against sickle cell disease, we could receive a list of all doctors specialized in sickle cell disease. So we work with that list of experts and we create a network. So once the network is created, we provide access to GPs. And as I said, those non-experts doctors can get information on treatment, on follow-up, etc. So this is very interesting. So of course, when you create an application, there's a trial and error phase, right? And are there some learnings that you'd like to share? I know that you started developing this on smartphones, and maybe it wasn't the right system to begin with. Could you please tell us more about your learning curve? Well, we realized that not all citizens in the DRC have an access to the internet. So the application was initially created on Play Store, but if the patient or the GP do not have an internet access, then they cannot have access to our application, and that's a shame. So we thought that instead of having a web-based solution, we would have a USSD app which can also work offline. So even if you do not have a smartphone with a regular mobile phone, the user can access all information pertaining to treatment, screening, etc. So Arnold, we see that one of the main challenges in e-health is the question of data collection. So with your application, are you collecting data? Are you harvesting data? What type of data? And what do you do with them? Answer. So we collect data for statistical purposes with the health ministry. Now the figures that we have are just rough estimates. We say that about 50,000 children are born in the DRC every year with sickle cell disease, but this is a rough estimate which dates back many years ago. So thanks to the application, we have more accurate data on sickle cell disease in a specific region, and so this is a work that is being carried out with the Ministry of Health of our country. Last question on this award and on this application. So you said one of the challenges is to develop this application, increase the user base. You would like to have as many as 100,000 users. How are you going to do that? Answer, as I said, we work with the Ministry of Health, and we are going to work on the dissemination of this application with a wider population, so that the wider public is informed that this application exists. So we hope to reach that threshold of 100,000 users in the near future. I do see that behind you there are many people. Are you talking from the AUF campus? Yes, that's right. I'm sitting here with students. They came here to support me, so I'm not by myself. Well, that's great. That's great. That's great to see those rooms which are full. I know this is a difficult time. You know, in regards with the crisis. So congratulations and bravo to people in Kinshasa. Congratulations. I'm sure that there will be many questions for you on the chat. I'm going to read one of them. Dominic in France says, well, congratulations. Thank you for sharing this experience. Thank you so much. Thank you for this message. Laura says, well, hello from Dakar. I'm delighted to be able to follow this conference. Dakar is one of the countries where we had a very good mitigation mechanism thanks to our community. Now, do not hesitate to ask questions, but in the meantime, we're going to have a presentation of the next project. In Guinea, Professor Fode Abba-Cissé is a neurologist at the University Hospital of Conakry. Can you hear us properly, Professor Cissé?
Allô, allô, est-ce que l'on a Fode?
Hello, do we have our professor connected or no? He's not connected. Okay, well, maybe we can ask, maybe the US? Because we have Sarah. You are in the US, you work a lot there. What time is it there? Are you connected?
Connected. Thank you very much. Can you hear me?
C'est parfait.
Yes. Perfect. Loud and clear.
Excellent. Yeah. So excellent. So it's about 8 a.m. where I am now, and I work closely with Professor Cissé and the whole team for the Guinea Epilepsy Project, and we're very grateful to be receiving this honor.
Ah, merci beaucoup. 8 heures du matin. On voit que les matinaux.
Okay, it's 8 o'clock in the morning. You're an early riser because you are living next to Boston. So you are awarded, both of you. We hope that Mr. Abba-Cissé will join us. So it's a little hat that was, in fact, will create ECG from a distance, so to detect the first sign of epilepsy. So this is a tool that will be a first worldwide. The Pierre Fabre Foundation is supporting this project. So of course your wish is to go one step further. The idea is to connect it to AI computers so that they could read the directly the recordings so that the doctors can screen the first signs and also then refer the patients to neurologists. So of course, we also will continue supporting that second phase of the project. Let's discover a little video.
Around the world. One is premature birth. Another is the sequelae of different infections of the brain can lead to lasting consequences. Finally, we know that there is an increased risk of head trauma.
La détection précoce des crises d'épilepsie permet de mieux la traiter. Ça augmente les chances de réussite.
So of course this helps screen the patients.
The next next step is to use AI, or artificial intelligence, and that will help us understand the vast amount of data we're able to collect from EEGs and potentially have point-of-care interpretations. Data from the electrode cap is transmitted to the app, which is on the tablet or the smartphone. We believe artificial intelligence is really the way forward for using EEG at the point of care and locations without experts.
Qu'on puisse former les gens à son utilisation et aussi qu'on puisse à court terme coordonner l'interprétation de ces examens effectués parce que le but c'est de faire le diagnostic et de prendre en charge ces patients.
We hope to use artificial intelligence and apply it to EEG in low resource settings, just like in the Guinea Epilepsy Project.
Voilà, Guinée Epilepsy Project qu'on peut applaudir.
So this is Guinea. We could have a warm applause for this project. So we are going to now have Farah. So we speak of Guinea and US, but it's a more global project, worldwide project, especially in the second phase, because the idea is to fuel computers to develop the algorithm. And then there are other universities that want to work with you.
That's absolutely correct. So EEG is an older technology, but there have been two challenges. The first is the technology to capture the data, which we have worked on in phase one. So we're trying to bring a very expensive piece of equipment to something that is mobile. So we've been able to accomplish that to some degree. The second part, which is equally as difficult, is to take the data of the brain waves on the app and actually make it usable at the point of care. So currently, you need a neurologist who reads the output, and that can take several minutes. And often there's a long delay between collecting the data and interpreting the data, because the data right now requires a neurologist, which takes approximately 10 years of training. So what we want is to use computers to automatically interpret the data based on trained algorithms. And we are working very closely with universities. I have collaborators at Harvard, where I work, also collaborators at the Danish Technical University in Copenhagen, and working very closely with Guinea and our African colleagues. But their epilepsy affects 1% to 2% of the entire population globally. So we want to be able to use the Guinea Epilepsy Project as a demonstration of what can be done, hopefully throughout Africa and other countries, including in high-income countries, because this challenge is everywhere.
Farah, vous faites écho à ce que nous disait.
Farah, I think what you're saying, as Derek was saying, he said that the challenge is to really work together, have a community of projects, and we can see that this project is a token of this. So I think on paper, in writing, it seems simple. We just are going to train the computer and read the scores, and then we're going to give them figures. But in truth, it is not. It's very, very tough to do.
That's correct. So this is, I think, a really good way that we've been able to collaborate. So in the US, we have thousands of EEGs we performed on epilepsy patients, and we can use these data to inform our model. But one of the issues is making sure that we're both sensitive and specific. So we want to be able to capture changes, but not capture changes that are not important. So this is going to take multiple iterations of the training. It's going to take engineers, computer scientists, software scientists, as well as the clinicians. We think it's very important because Guinea has only 5 neurologists, and there are 12.5 million people in Guinea. So we know neurologists, that person can't read all the EEGs for the many people with epilepsy. So the computer has to be able to help. We just have to work with it.
Cela veut dire quand même, Farah, avoir aujourd'hui des...
So this means that you need to give all this data to fuel and really get that. So where do you find this data, mass data and high quality data?
Right now, we are starting with the data that we have from Boston and from Denmark. We're using known diagnoses of epilepsy with standard EEG machines. And then the next step is to take our mobile EEG data from phase 1, at which time we collected more than 500 EEGs from the mobile app in Guinea. And then we will use those data to train it again. And the hope is that with several repeat efforts of this process, that we'll be able to at least understand quality of EEG and what we call spike detection. So we won't be able to provide a full read immediately, but we're going to take one bite at a time, little piece by little piece. And I think with concerted efforts, we will gradually get there.
Farah, on a de la chance.
Thank you so much. We have now the connection with Professor Cisse. Professor, congratulations for this wonderful award for the observatory. Now, is it frustrating or rather frightening to say tomorrow a computer will be able to do my job? Exactly the same job as a doctor and could even be a better doctor? No, I don't think so. I think the idea is to really work with computers and not replace one another. I think that the ECG, and this is a gold standard a diagnosis to confirm, but you know, the doctor will confirm the diagnosis. This is not going to be done by a computer. In fact, has to look at the epilepsy episode, and then this is going to confirm this by an ECG. So this is what we call a clinical confirmation, but in no case it will replace a diagnosis. So it's good to have innovation, something quick, and maybe having a good, I would say, confirmation of epilepsy episodes. Now, Professor, you talked, because you said, okay, it's nice on paper, but in reality, it's not easy to have an algorithm and having high quality data. And in addition, you know, the human touch is not going to replace, you know, if you have 30 different neurologists, they will have interpretations, different ones. And I think the computer has to also learn how to take this into account. Yes, I agree. But as we said, we are trying to stay optimistic. The idea in Africa is to record the activity of the brain. Of course, then there's AI algorithm, but the fact of having already an ECG recording the brain activity, this is already a step forward. Learning how to read ECGs and make it more commonplace. I think that's quite nice, and we will see how AI can even help us further. So when is your deadline? 1 month, 6 months, a year? When will we have this tool? When? Ah, that's a good question. We look, the hat is already here. The little box is here. Then there's the tablet with the connection. So I think that's already a good step. Now, the algorithm is more in the hands of engineers, and we will see. Okay, I'll send the question because she's with us.
Algorithme, c'est pour.
Farah, when is it? For tomorrow? 3 months? 6 months? A year?
It's already finished, but the reality is it always takes longer than we expect. And so we know that for the heart, it's relatively straightforward. There are only so many leads. The brain is very complicated. So to answer the question, with the foundation, we are planning to make significant progress in the next 12 months. But, you know, there are a lot of nuances. So we will start with adults, and we will start with quality of EEG and spikes, and then we will make it more complicated after that. But we're hoping in the next year we will show you progress. Maybe this meeting next year we will show you something.
Ah, c'est bien, ça c'est bien. La Fondation vous met la pression pour accélérer encore plus la réalité du travail.
Thank you so much. Another question, Professor, in Conakry in Guinea. Now, the support of the Foundation Pierre Fabre, is it important for you? Very important, because this means that we can continue moving forward, having some electrodes on the hat, more material to record the activity of the brain, and also maybe remove the stigma when it comes to epilepsy, because obviously these patients are, we can talk about the disease, we can talk about, so the fact that having more information, in addition to the development of innovation, but the fact of talking about epilepsy means that people understand the difficulties and removes the stigma of these. As Farah has said, next year maybe we could have the smartphone available for Guinea, and why not for Africa? Well, we cross our fingers, and congratulations to both of you. Warm applause. I think they deserve this. So we will have a lot of questions on this project. A very ambitious project from a tech and social point of view. And now we will see a couple of questions. If you have any questions for our three awardees. A lot of questions already on the net. The first one is Professor Cissé. François Charles is asking the question, saying, Professor, it would be amazing to have this in in the Upper Guinea, because epileptic patients are considered as crazy people and they are locked in psychiatric hospitals. Yes, as Charles-François just said, if he knows Guinea, it says that 2/3 of the territory has no neurologist. So if you have a patient who suffers from epilepsy, well, they cannot treat the patient. With the smartphones, we can help that. We can have caregivers. So it's very important to have what we call adapted low-cost diagnosis tools, easy to use in remote areas. So again, as I said, there's a lot of stigma. They are mistreated. Sometimes they are removed from their families. So there's a social cultural consequence. Gradually, we are trying to improve this with free consultations and so on that we organize with Farah, but there's still much more to do, and we need to have tools to remove the stigma around epilepsy. Another question in the room. So we have comments in the room. And another comment, we always learn a lot from your meetings, so thank you so much. And thank you for these heartwarming messages. Now, Babacar in Senegal is saying that these TT trackers, digital solution, is a good way of tracking indicators and also is a great decision-making tool. So thank you for writing your comments. Then, in Navarre, we have a question. My name is Robert Giraud on sickle sick disease. I have a question. I have a question for him. I think that the application that informs on sickle cell disease, sorry, there's a problem with the sound. Anyhow, I think your application is great. And I have a question on how they use the tools by the patients. Did you think of summing up for the patients in 10 sentences the main symptoms of this disease, and could be shown when the patient goes to see a doctor? Why am I saying this? Because I know a lot of patients are reluctant, they are hesitating because they say, the doctors don't know about the disease. But if you have a little summary of the main description of the condition, then that could be a definite help. Well, we always inform, some patients know well their disease, and so when they are in front of a doctor that don't, what happens? In my app, there is the possibility for the patient to, they can have the address and name of a doctor that knows about the disease. And then there's also a kind of forum, dialogue. People share their experience, giving advice. And sometimes this is for the application. Okay, thank you. Any other questions, comments, questions for our 3 awardees of 2020? So we have another question from the room in Lavore. And again, from internet, don't hesitate to ask a question. Hello, my name is Isabelle from DataCraft. I have a question for Sarah. If I understood well, the data analysis is done by the ministry. Do you also work on how you're going to collect the data? Because, you know,
it is definitely managed by the Ministry of Health, and inside the Ministry of Health, there's always an NTD department, the Neglected Tropical Disease Department, which the trachoma program sits under. So it's really that team that we help. And so our SiteSavers support team for the TT tracker does have access to that data to be able to help them with data cleaning. So part of our purpose, I think, with the TT tracker is not just to give software, but to also be able to give the necessary support to use it. So we have a team that does biweekly check-ins with the ministry representative, who's the administrator of the system locally, and they go through and look through a data quality dashboard and do all those things. So I think we're just trying to give an extra push to make sure that all of that is happening, even though it's certainly in the hands of the ministries.
Juste en complément de la question de madame, ça veut dire...
So to conclude, locally you have specialists that are capable of analyzing the data, or do you call upon other specialists in Europe, in the US?
When we go into a country with a TT tracker, we have the Ministry of Health choose an administrator. So they're the person who's going to be the lead of the system, and we do the training with them to be able to pull reports, analyze data, and do everything that any of the projects or the program would need them to do. So they're the ones who are managing it in country.
Ouais. Autre question, attendez que nous arrivent des internautes pour...
Another question, maybe for Sarah, another question. Someone is asking how can you cope with the challenges of data quality? Do you have what we call a mechanism to have a close follow-up?
It's impossible to do anything 100%, but I think some of the things we've touched on lead towards that. So making sure that we do the suivi at the 100%. All we can do is make sure that the information is there and that the programs have a push and the ability to find the patients who need the follow-up, and then make sure that the project is supervised properly, so when that doesn't happen, somebody asks questions, say, why is this follow-up rate low and what's going on here? And that's part of having that supervision and having that dashboard of live data so you can make decisions as things are happening. And then on the data quality question, back to what I was just saying, a minute ago, we've got this data quality dashboard, so it flags anything that looks like it should be out of range or that needs to be analyzed further, and so that at least keeps the data clean as it's coming in, because it gets stuck somewhere before it can move into the central database. So.
Ouais. Autre question sur TT Tracker.
Another question on TT Tracker, more technical question, but at the same time links up with what we said this morning. Is it 100% ownership by the teams, or you had you went to see the GAFA to analyze the data on the cloud? We talked about Microsoft, but why not Amazon? Because they can analyze the data, geolocalization, mass data. These are very much used tools.
We took the road instead of using software systems which already exist and they're relatively low cost, and configuring those to our needs. So we've used a few pieces of software that are either open source or low cost compared to something that would come out of Silicon Valley probably. And we've put
a lot more importance, I think. I mean, the software is important, the application is important, but we've put a lot more of our focus on the collection of the data, the quality of the data, the use of the data. So those are skills and things that are important with any technology and, patient tracking or any sort of data collection of any kind where we're working.
Autre question que nous pose un internaute pour un...
Another question, still for Arnold Vogbo, the application ANEMIAP, is it available in other countries in Africa? Arnold? Okay, no connection. Sorry, I feel that we are disconnected with Kinshasa. Okay, Arnold, did you listen to the question? Okay, we're losing you. Okay, we'll see if we can get connected afterwards. We have time for a last question. We will have a question from the Minister of the Health of Burkina. Okay, sorry, Aminia is back with us. So maybe the question from the Minister and... Thank you very much. I would like to firstly thank the organizers for this meeting. And we can really look at the implication, the contribution of the foundation. I don't have a question as such, but I would like to really congratulate from my heart the fact that you are really showing that it's not just e-health, but it's also the decision makers has to be well directed, and the foundation has shown that we can reduce the mortality rate because of and thanks to treatment. I'm thinking of sickle cell disease. It's unfortunately in fact diagnosed at a late stage, and we cannot cure this. And I also wanted to pinpoint the epilepsy. So a lot of cases that we have, and I'm delighted to see that we have now data that could really help us make the right decision. So thank you and congratulations to all. Thank you. From Lavar, thank you. All this is important. We are going to see if we can ask one last question to Arnold on sickle cell disease. Now, this application, do you think we will have it and see it elsewhere in Africa? Yes, we have started in Congo Democratic Republic, which is the third country that has been affected by sickle cell disease. In Africa, we have 80% of the patients. So that means that we need to expand our project to other African countries. Well, we, of course, are behind you, and we hope that you succeed. Congratulations to all our awardees. A warm applause to all these digital projects that are definitely driving transformation, and we can see more of that. And because we speak of epidemics, we speak of lockdown, and so all the digital uses have been really important, whether it's distance learning, distance shopping, teleconsultation, video conference. Our daily lives are becoming even more digital, quicker, and I think that this will last. Now, in terms of health, the next question is, are health crises are drivers, boosters of e-health and digital health? This will be the question of our next roundtable.
Voilà, les crises sanitaires comme accès.
health crisis accelerating the digital transformation of health system. To answer this very, very serious question, we have the Minister of Health of Burkina Faso, Léonie Claudine Lux Sorgo. Thank you so much for having traveled, complicated traveling conditions, just to come to see us at the Foundation of Pierre Fabre in Lavore in France. Please join us. Then Professor Antoine Gus-Buller, who is a Chief Medical Officer, eHealth Telemedicine in Geneva, coming from Switzerland. Please join us. Thank you. You're also a director and of the French-speaking African Network. And Florence Gaudry-Perkins, who is here, third seat. Please keep the distance, social distancing. So you founded the Digital Health Partnerships. You are a consultant for the governments, also in eHealth, and also with us, connected from the States, from Atlanta, the Dr. Carl Kincaid, who is an expert at the Centers for Disease Control and Prevention, federal agency in the U.S., has had a long international experience and career in the field, in Africa, in Asia, in Middle East. So thank you so much for being connected from Atlanta in the United States. So first question for our Minister of Health. What is your feeling regarding the questions? You have a microphone if you want to. I'm going to remove my mask because, I won't be able to feel free to answer your question. Okay. So we saw that in Burkina Faso, you have a tool to get data in health. In addition to this tool, that should help you better manage your health crisis. What do you feel? Do you feel that there's, I would say, a speeding up of all these tools? Thank you. Thank you for inviting me, giving me the honor of kicking off this roundtable. Now, the government in my country has become more digital and dematerialization of the data. And that has been the case for some years. And I would say the major application is what we call the concentration of data from the districts. Because firstly, I need to maybe describe how we organize our healthcare. It's 3 levels. There are primary care, secondary care, and tertiary care. And then we have a district-like organization and central. So we have 70 districts in Burkina Faso. And the data from the districts are generated from baseline, because we also have health caregivers who live in the communities, and they can manage the essential problems. So all this data is then sent with, so this is going to be sent to centralized, what we call DH2LT, so that is to say District Health Information Systems, and so on. That's the acronym. Anyhow, level 1, level 2, and so on. And so thanks to that, we're able to centralize all the data. And having what we call a statistics register, and this is a good application, with the help of partners. And when we treated children under the age of 5, now when we decided to give free care for these children, so we obtained the data to show how effective that was for young children. And then, second part, the pandemics that of course came and speeded up the situation, but we were already there doing that in the eHealth. And with Professor, we developed the the e-health register. So what you are saying is that you said we already had a strategy in e-health, whether you are you getting feedback or sharing feedback with young children, because that is one of your priorities. So in the situation of a pandemic, we speak of COVID now, but unfortunately there were other pandemics. For us for you as a minister, how do these digital tools have made your decisions easier? Did they change your work as compared to 10 years ago? Thank you for this question. In Burkina Faso, we have several challenges. Security is number one. The fact of having data means that we can continue giving care in displaced population. Because if you have a terrorist attack, then we have populations that are displaced, and we can follow these populations thanks to digital data. And so this is, again, thanks to the application of CDC Africa and Atlanta. And so we were able to keep a social link. And social partners had decided to keep the data. Now with tablets, thanks to the help of all these partners, unfortunately I cannot name all of them, but the health agency has generated some data that we could report in DHT2. So that was a big help to be able to cope with some challenges, but also help us make the decisions. What kind of decisions? Well, monitoring unexpected events. Imagine, if you have unexpected events, the data can help us detect this on time. By this doing so, we can investigate at a timely manner. Whereas before it was a weekly report, so that means that you needed to wait for a week. Today, it's real-time reaction. Of course, there's the problem of continuous connection, but we also use text messages thanks to the mobile phones. We can use the text messages so that we can have a day-to-day updated data. Because when it comes to health, the decision is essential, and that's how you can save life. Yes, if you master time, you master a crisis, as we say, says the journalist. Okay, Antoine, the COVID crisis obviously has had a speeding up effect. In your own facility, yes, well, in my center, overnight, we saw that digital played a strong role. We were treating COVID patients, but not only. So overnight, we have decided to deploy 400 telemedicine stations. 10 days, you did in your hospital 400 posts of telemedicine for the doctors. Yes, so that they can continue follow their patients for whom they couldn't come to the hospital. So you were able to treat the COVID patients. It's a crisis. And at the same time, thanks to telemedicine, you were able to continue working almost normally. Well, for chronic outpatients, yes, it was a major plus. How many teleconsultations did you perform? Do you have figures? Well, several thousands. That was done during the 4 months, the peak, and then gradually things went back to normal, and then preparing for the second wave that is happening. And so maybe that will mean that we will be under more stress and better understand what is the role of these technologies that we have been using for some years now. But in countries with low distance, we're not that important, but now it is. because of the current health situation. But of course, mindsets are changing. So suddenly our doctors saying that there are some consultations that they can do just as well. Instead of asking the patients to come to the hospital. We are having an aging population. I think it's a way of protecting and having better quality care. So I hear a lot in what you said. Firstly, the habits of telemedicine we saw now with Burkina Faso. And then secondly, you are not taken by surprise because you're able to deploy 400 stations. So in other words, you were able to continue working almost normally. It's impossible because doctors accept this digital tool. Can you tell us a little bit more? Up until now, we saw that only a few of doctors were fans of this, but not that many. Telemedicine, they were afraid of that. They didn't want that. However, with the crisis, we are intensifying this use, what we call a mass use, and everybody has to accept it. Everybody has to sign up for telemedicine. So how do you explain that they've accepted it? Well, there was a couple of weeks where there was not any other option. It was the only way. So, you wouldn't even think, do I need it? Do I want it? And so on. No longer questions because there was no other alternative. So the fact of being, faced with that. And so it's true, they were obstacles because they were concerns, but clearly we saw that for some doctors, they weren't really happy about it. But then clearly they realized that these tools have deserve to be used because, and it's not just during the COVID, it's even beyond. One example, a regular follow-up of diabetes patients that normally have to come to the hospital. It's not easy. They have to travel from where they are. They can't really walk properly, whereas they could also use these tools and then maybe have more frequent visits, consultations to have a better home care. Another way was to say having caregivers that used to go to the home, having quick access to experts or home nurses that could maybe call ER doctors and avoid having these patients come to the hospital in intensive care, because a lot of times you can find solutions at home, which was good for the patient, for the doctors. And so we were, in fact, with these tools, we are more effective. And, the entire health system becomes more effective. These tools, do they change the relationship between the doctor and the caregiver and so on? This morning we said that one of the challenges is to keep the patient centric. The patient has to be proactive, giving information on the disease, and so we are part of the medical approach. Do you see a change, a cultural change? Yes, we see it, but it's nothing new. The patients are now more empowered, I would say. And then for the past 2-3 years, we see that patients want to be listened to and even proactive. So it's no longer a process that is patient-centric. It's really a team that really includes the patients, the relatives, and so we have a team that really works hand in hand. So it's very different from saying it's patient-centric, but this has been the case for 10 years. Of course, it's going to be, I would say, fostered by digital, the fact that in fact patients can speak to one another, which is not always what doctors like, but that's another problem. But anyhow, that's this ability to understand, to really embrace their own problem, and also having a more empowered, more proactive attitude. This is something that we see. I wouldn't say that the COVID today has changed that. The tools that we have were tools that we had that would get close to the typical consultation with virtual waiting rooms and so on, and that kind of duplicate what their professional lives were. But we do see, however, the fact that the patients are feeling more responsible, they are feeling more active, and this is definitely something that we have seen. And that also changes how we devise our tools, because part of the tools that used to be developed only for doctors or only for health professionals and hospital staff, now they have another version for patients, for caregivers, having access to this information. In 10 days, you said 400 stations. Because of a crisis, more digital way of working. Was this easier because you had already worked in e-health? Was it easier? Of course it was, because that was also what we talked about this morning. I said that a lot of countries from the South are experiencing a health crisis, and we've had that for years and years. And I think that even 20 years ago, we understood that these tools, digital tools, not to solve everything, but rather to really help between the big cities, the rural areas. These tools can really support the professionals where they are, thanks to digital. And, in Mali, we saw that in other. In fact, you learned from your experience in Mali. Of course, what we also learned from African countries, the setting up of these tools is 20% of technology, and the percentage of technology goes down with, and 80%, it's more organization, understanding, embracement in the processes, also in the strategies, national strategies in health, and so on. So all this work has helped us in fact, set up tools that work. And so when we deployed this in Geneva, in one of the richest cities in the world, we saw where the 4G wouldn't work, and the fact of having resilient tools being capable of, are easy to use by people who are not IT geeks. For example, so suddenly these tools are easy to deploy. So I would say we made the most of our 20 years of experience that we gained in Africa with telemedicine, and that really made the situation in crisis easier in Geneva. Yes, so making the most. Thank you. Now, you also talked about more and more use of digital. You had no choice during the crisis. Now, how is it today? Do you think that the habits are here to last? Well, during the summer, we went back to normal. I know that today we have a second wave. We have more COVID patients, elderly patients, so therefore risky patients. So we will have to face a second wave. So we've had time to prepare and think and anticipate. So these uses are going to evolve with the crisis. The fact of having had a test and tried situation, experimented other modes, that means that we no longer experience things differently. One of the things that have modified, I wanted to mention this because we talked about the challenges around data, to understand how much we needed to control our real-time data. And I'd like to thank the Burkina Faso collaboration. We have been able to work with the Ministry of Health on tablets, on follow-up consultations, children diseases. We have 2 million consultations, and we have been able to duplicate some techniques, AI, machine learning, identify. So the first thing that we have been able to identify is what are the caregivers that perform well, those not as well, and those who perform well can teach the others to use the system. Another thing that we have been able to deploy a couple of weeks ago, daily dashboards that inform the decision makers for health districts. So this experience, we have been able to symbolize it in what we call a 2.0 hospital, this ability in real time to say, where are the resources? How do we position the patients according to their contagious situation or vulnerable situation? Very interesting, because 20 years later, I see the fruits of my work, of what I learned in Africa. And I know that, during a crisis, these become essential. So clearly, it's a north-south learning.
Well, I'm listening to you. I'm fascinated by what you're saying, but I'm also surprised by the world in which we currently live. We do see that on the one hand, the United States and Guinea are working hand in hand, also in Denmark. So we do see that collectively we have a development of such a tool. So it's not only a north-south relationship, but it's again a multilateral partnership. And again, what you're explaining from Geneva, so it's a changing paradigm. I think that we've witnessed it the last 20 years, right? Answer, well, yes. When we started, the expertise was in the north and we would be transmitting that to the south. But then we realized that it was not true. If we want to make a difference, we have to have a sound knowledge of the grassroots level. We have to understand the social environment, the culture as well. And so when we have everybody around a virtual table, then everybody does contribute to the conversation, and this is the beauty of those networks. Yes, I would like now to address Carl Kincaid from Atlanta. You're an expert at the Center for Disease Control and Prevention. This is a federal agency. You also worked very much in the field. You observed how the Ebola crisis was managed. Now, have you seen a change in digital uses? Do you think that digital tools radically transform the healthcare systems? Do you have concrete examples that you experienced in the field?
Well, yes. I mean, I think there's an expectation that digital tools will be used. I think no one wants to go back to the days where everything's on paper and you're doing data entry on paper and then doing interventions with patients, to sort of get ahead of a response. My world is in first response with CDC, and like you had mentioned, I was in Liberia for Ebola, and in Liberia, the case bases were all case-based data, and it was all on paper, and it came in. But post Ebola, as we started establishing or working with the Ministry of Health to establish their IDSR and then later EIDSR, the Integrated Disease Surveillance and Response, Liberia wanted to stay with case-based data. They didn't want to go back to aggregate data. And so their IDSR was set up for their 14 diseases as case-based data. And initially was all in Excel, and realizing the sort of painful process that was, having. They wanted to go to EIDSR, and they've since established, at least in part of the country, it's still being rolled out, a real-time surveillance system from the health facility level up to the national level. I just moved back from there last year. I lived there for 3 years to help them recover from the outbreak. And I still remember the day the Director General for the National Public Health Institute of Liberia, he was in Beijing for meetings, and he received a text message in real time that there was a suspect Lassa fever case. And he talked about it for the next 6 months. And we said, that's the point. The point is that technology allows us to know what's going on in our communities better. They allow us to understand what the response needs to be. They allow us to adequately respond and prepare and then craft that response in more real time. When I look back at, in 2008, I was in Myanmar after Cyclone Nargis to help with a rapid assessment with OCHA. We couldn't use digital devices. We used paper. And so as you can imagine, out in the southern part of Myanmar, when it's still rainy and bad weather and a lot of destruction, you have teams on the ground collecting household surveys on paper. And they were hauled back to Yangon, where we did double data entry. And then, of course, in that process, you have to go back and fix errors. And all that has to come before you can even start that report to Geneva. And, fast forward to 2010 and Haiti, when I got to Haiti, OCHA, I came in and some of the same people I was in Myanmar with were in Haiti. And they said, Carl, we want to do the same thing we did in Myanmar, but not on paper. And so back then we used PDAs and we did the initial rapid assessment on PDAs. And that it eliminated that double data entry step. It eliminated errors. It made it more rapid and allowed leadership to get information they needed to make decisions more quickly. And so I think there's an expectation across the globe now that we're going to use technology. And we're not going to, no one wants to do stuff on paper. Sometimes you have to, but the thought of filling a truck with paper and driving out to the field to collect responses is painful for everyone.
On voit à travers les exemples que vous donnez là.
So we see with your examples, we see that the tools really help in saving time, also help in making decisions in a quicker, swifter way. This is very interesting in case of an acute crisis. Now, don't you think that there's also another type of change in the way those tools are being developed? We see that with the epilepsy project, where we have this collaboration between North and South. We also heard this project from Burkina Faso in Switzerland, where there were lessons learned from on both sides. Do you have the same observation, the fact that the South-North relationship is changing, is that crisis also changes the outlook that we have on our partners?
Well, I think that, that when people use technology, and of course, as Liberia as an example, donor organizations like Gates and others want to invest in technology-driven solutions, and that investment helps with that response. But then that investment lives on into the next steps of routine surveillance and active surveillance and integrated diagnostics through laboratory and of course response efforts and emergency operations centers. All this stuff is technology-driven. You can not use it. And in parts of Liberia, as an example, where there's not data coverage, it still has to happen that way for part of the country. But as technology changes, infrastructure changes, that all, of course, changes. I think that there are differences, of course, between countries that have more infrastructure and more penetration of digital technology. If you look at South Korea versus Liberia, it's a different population where technology and smartphones and the like are throughout the society, and it's an expectation. Can you imagine South Korea agreeing to do anything on paper? Probably not. But at the same time, as I look at some of the response efforts in Africa, where a lot of time has been spent around infectious diseases and contact tracing and response efforts, in many ways, they've done better than the U.S. has done, for instance, because that's not what we deal with. U.S. tends to focus on chronic diseases, and infectious diseases are usually small clusters, occasional larger, E. coli or Salmonella outbreak. But other than that, they're typically smaller and not something like we're experiencing right now. So in many ways, if you look at what Liberia has done post Ebola and currently during the Ebola response, in many ways they've done a better job than many of the other countries because so much time and effort by many partners supported them to get to where they're at.
Vous m'avez surpris lorsque l'on préparait cette table ronde.
When we prepared this round table, you said, well, my job is not to have something to do in Liberia in case of a pandemic. Could you please develop or elaborate on that?
Sure. I think, all of us love to work with our partners. And you know, when you work a lot in a country, you, of course, establish strong connections to the people there and the organizations. And of course, I have many close Liberian friends, and I love working there. At the same time, you know, if we're doing our jobs right as partners, then we work ourselves out of a job. You know, you build that capacity in country to where Liberians are taking care of Liberia. You know, not Americans, not CDC, not WHO. You know, that should be the goal. How do we build that capacity across the globe where countries can take care of themselves and there's sustainable solutions? I think it's always very easy for partners to come in and stand up a partner solution. And I think that's where we have to be careful. And I think that the more we work together and we collaborate across organizations and we really focus on truly sustainable systems for the Ministry of Health, then we work ourselves out of a job, and that should be our goal.
C'est particulièrement intéressant ce que vous nous dites, plus nous travaillons ensemble.
Yeah, you're right. The more we work together, the more we're going to find solutions together. Now, when you think about the fears that there are currently vis-à-vis the United States, we know that there is quite a number of health data are hosted by Azure in the United States. And so we had this conversation with Morning around GAFAs. Should we leverage the tools like Facebook or other social networks just because they have this strong power and they are able to connect us to a number of people? Should we use the tools of WS, of Amazon? They also have face recognition. They have calculation speed that are a lot stronger than any state could ever have. But in a nutshell, what should be our attitude vis-à-vis the GAFAs and the United States at large?
Well, I think that you know, we all know the power of the social network, you know, social network and social media and the companies that make and host these services. And there's some very, very good tools there. I think that we all just have to be also cognizant that you know, that things happen, you know, that there's always a potential that your data will leave. You know, I remember, and I hate to go back to Liberia as an example, but one funny thing that happened toward the end of the response, as we were talking about how to move toward a cloud-hosted EIDSR, one of my colleagues in Liberia had commented that they didn't know if they were comfortable with hosting in the cloud. But throughout the response, they were backing up their Ebola data and emailing it through Gmail as a backup. And so I joked with them that you're already using cloud hosting, but in a very poor way. And so, you know, you can be smart about your hosting. I think these companies are good companies. I think their intent is most of the time right. I think there are other stuff that happens. But I think that as long as you're smart about the way you use them and you're careful and cognizant of the risks, that you can do it. Now, we as CDC and the U.S. government, we have some AWS government services, but they're separate. They're separated from the other components of AWS, and that's the way you start to use these services in a smart way.
J'aimerais bien connaître votre opinion, Antoine Gazbula, sur ce sujet. Effectivement, on fait tous le constat sur.
So we all realize here around this table that those tools, especially during the crisis, are being more and more widely used. And those tools also open up new avenues for patients, but also healthcare providers. Now, again, most of those tools we're talking about are directly linked to one country, and we're talking here about the United States. So is it a source of concern? Answer: well, those tools are designed in such a way that they can be rolled out very quickly the world over. So we're going to be pretty much challenged if we want to do you know, just as good as they do or hardly as good as they do. So we need to find a way to have we need to find a way to use them while be cognizant of their risks as well. And so I concur with what Carl Kincaid said. I think that the issue is not so much the companies which developed those tools, but rather a question of sovereignty over data, data protection, private life protection. And those are, rather the questions that we have to contend with. You have the Patriot Act, you have the Cloud Act, you have all those mechanisms that are at play, and the underlying question here is data sovereignty. Yeah, but on the other hand, you have a number of users saying that GDPR, the European regulation, is also a hurdle in the use of data that we collect. Well, you're right, but that GDPR was also a long time in the making. And there were many negotiations, and I'm under the impression that tools are being developed quicker than legislations. I think legislation will always be lagging behind, and we have to accept that. Now, when we have a consensus, when we have standards, for example, so GDPR, I think this is really, it really embodies a will from the population to strike the right balance between having access to data because it helps in solving data, but at the same time protecting those data so that each citizen is reassured on the fact that their private life is being protected. So we need to we should strive at striking that type of balance with the GAFAs and also the governments behind. This is complicated in the current context. We hope that things are going to make headways, but big entities like Europe have strong solutions or strong proposals to try and influence those discussions, but discussions will have to take place. I think, some people think that all data should remain in the country, should be controlled by the countries, but there are limitations, and there are good examples that were given by Carl. So there is no straightforward answer. We need to keep our values, the values of our society, and we need to, we're facing a number of dilemmas: public good, individual liberty or freedom, but also the interest of a wider community. This is nothing new. This is not something that was created by COVID. It existed before. So we need to recognize that, and we should try to be smart about that. Florence Perkins, you are the founder of a startup named Digital Health Partnerships. Do you also agree on the fact that health crises do accelerate digital transformation? Well, I think that there's a strong acceleration in the digital transformation in the health area. You have to know that the use of the internet was multiplied by 70% in the lockdown period. So this is no minor feat by the mobile providers or internet providers to contend with this very steep increase in internet usage. So of course it helped. It helped us to stay in contact, and it had a positive impact on digital health. And you cited a number of examples. Now the crisis, and I would like to talk about this because I think it was not discussed today. The crisis also highlighted the fact, the gaps and the differences in the different layers of society. And this is not a north-south problem, it's also a north-north problem. Of course, the problem is even more complex in countries with less revenues, but 3.6 billion citizens do not have access to the internet. So the COVID crisis also was a way to highlight those gaps, those differences. we knew that before, but I think that there was a collective recognition of that. Now, on digital transformation, Professor Geisbühler also mentioned that there were changes in usage for healthcare providers, for patients as well. I also observed that with telemedicine, many legislations became less stringent during the crisis. In France, there were also the possibility to have telemedicine or teleconsultations to be paid for by the state insurance system. This is something completely new. I also recently read a survey in which they said that three-fourths of GPs in Europe agreed that digital tools were a lifeline in their daily life and really helped them contend with the crisis situation. Now, when it comes to data collection or access to data, I also have a number of colleagues saying that during the crisis there were more data exchanges than ever. So it really helped with that. It really helped with data circulation. Now, on telemedicine, as I said, this is an area which I know quite well. Hani Ekskandar from the International Telecommunication Union talked about this morning. One of the first applications in the wide field of e-health were the digital tools. And there are a few figures that I would like to mention. Well, in France, the beginning of March, we had about 10,000 e-consultations per week. At the end of March, we had 1 million teleconsultation per week. In China, Pinhang Good Doctor, it is a telemedicine service. Of course, we're talking about a scale which is huge, 200 million users in China because they have so many inhabitants. They had plus 900% of consultations between the beginning and the end of lockdown. In the United States, 11% would be using teleconsultation, 46% would use teleconsultation at the end of a crisis. So there's really a boom of those teleconsultations. Now, my question would be, is it going to be a durable phenomenon? Well, as Professor Geisbühler said, well, those figures were reduced when the lockdown was eased or lifted. But I think it really changed the usage. I think it's a lasting change. And beyond that, and I wanted to concentrate on things, I think that telemedicine or e-health really depends on the rules and regulations that are implemented. Now, telemedicine, well, in our country, has to do with the right to write a prescription, to send a prescription. Is it possible to send a prescription via Gmail or Google Mail? And then in our country, we also have those questions with the state health insurance. Now, during this crisis, there were incredible side effects. In our country, in France, we were pretty much advanced when it comes to teleconsultation. Before the crisis, it was not possible for you to consult for the first time for one condition if you had not seen a doctor before for the same disease. Same thing in China. You had to see a doctor in person before you had a teleconsultation for follow-up, for example. So in a number of countries, those things were changed. This was the case in China, in France, in the United States as well. So I think that those changes in the rules are not going to go back to the situation pre-crisis. I think those are there to stay. So the thing is that you mentioned about telemedicine, e-health, whatever the name you want to give it. For a long time we thought that it was a gimmick, that it was a gadget, that it was good for countries in the south because they have so little doctors. And so it was almost a source of contempt for GP in the north, where people would say, well, you know, you can't really have the right diagnosis through a screen. Now, what you're telling us is that the sanitary crisis completely changed and brushed aside all those criticisms. Well, it didn't completely brush aside those criticisms. Not everything can be performed remotely. However, there are more and more options available thanks to connected devices. You underlined the solution for diabetes, what you can do remotely when it comes to diabetes monitoring. I'm also familiar with the booth for telemedicine, where you have 15 connected devices and you can have an ECG, an EEG, and a number of tests. So there are a number of options available to monitor the vital signs and things. So there are still a number of hurdles, but telemedicine has made a lot of progress. Antoine Gaispola, again, I would like to ask this question. Do you think that health crises do accelerate digital transformation of health systems? In the past, those tools were considered as gadgets. They were not really considered real health tools. Don't you think that this has changed? Don't you think that now people are more aware that those are not gadgets, that things are lastingly changing, that there is a before COVID and after COVID? Well, you know, it's difficult to talk about a post-COVID situation because we're still pretty much in the middle of COVID crisis. But anyway, during the first lockdown period in France, there was a tenfold or 100-fold use of telemedicine during the first lockdown, and then it decreased, but then it's going up again. Now, what's interesting is that even in the well-off countries, the health system can be put under such a strain that we need to think about the whole system altogether and rethink the whole system altogether. So indeed, there was already a conversation in northern countries about aging population, about follow-up of elderly patients, etc., etc. And it's true that telemedicine, and this is what we did as well in Sahel countries when we started the RAFT network. We had a network of GPs, then nurses, then midwives. So you have a chain of community-based healthcare workers, and now we are able to provide care even in remote area when in the past you had to travel to the capital city. So this really changes the way we think in terms of how we organize the provision of care, also in rich countries. And I think this reflection was certainly sped up by the crisis. And those are, we had to ask ourselves questions that we never had to contend with in the past in northern countries, because we feared that a hospital would be saturated. Now, those are questions that we have to contend with on a daily basis in countries of the south. So again, digital tools are not here to replace a GP, are not going to replace them, but GPs are going to become augmented professionals because they're going to have more expertise, more information. They're going to have tools which are going to help inform their decision making. So I think those are those practices that are going to change. And also the viewpoint of our population. So we experienced a very stressful situation And we need to, again, keep the learnings of this crisis to have a higher performance system. And I'm sure that digital tools do have a role to play. Now, I have the same question for Carl Kincaid. So Professor Geisbühler here just said that there's a before and after COVID crisis. Do you think it's the same thing in the United States? Do you think that the crisis had you rethink the way your healthcare provision is being provided? Do you think that you can learn lessons from countries in the global south? Do you think that there's indeed a before and after COVID crisis?
A lot of lessons learned, throughout this response. We probably know that local health departments, which is the strength of our public health system, needs to have this capacity. We know we need to have standards around data collection and what those processes are and reporting systems. So there's a lot of sort of tweaking as this response is going forward by both local, state, federal. With the U.S., even though we're a federal agency, our role is to support the states, and the state's role is to support the local health departments. But oftentimes, the local health departments have the least resources, and so it's important, when you look across these, that you address it uniformly. But just by the structure of our system, each local health department can kind of address it individually. And that makes it a bit of a challenge on how do you respond to something that's this national in scope, and then the reporting process. So we have ongoing national surveillance systems, of course, and some of those, of course, are infectious diseases. And those have been used for years, and they work. But we're also seeing that there are challenges to the process of doing widespread contact tracing and the tools and who's doing what and what are those standardized forms and et cetera. So I think in that respect, a lot of the countries, when you look across some of the other countries that are what they've done with technology, if I look at Uganda, they've done some amazing work around their national surveillance system and their ports of entry and their lab integration and the like. I just watched a presentation by Mozambique the other day where they have this ports of entry app where the people who are traveling go online and they register and they download the app, and then when they get a QR code, back to them via their app, and then when they get to the border, they bring up the code and it's scanned, and their contact information is there. I think those processes can be used by everyone. It's irrelevant if we're America or Europe or Africa. Just that process of how do we make it the easiest for the end users, and that's the people, right? I mean, what can we do as organizations to help it, not just from a data perspective, easier for end users, but they get access to care and they get access to their own information and it's protected. I think all those are lessons we learn from each other.
Toute dernière question, Antoine Geisbühler, parce que je voyais aussi.
Very last question. We also have many questions on the chat. We discussed very much of healthcare systems before, during, and after the crisis. Now, what about our patients? What about the users? Are we also asking them to change, to accompany somehow those new tools? Well, those new tools really helped with the empowerment of those patients. So to make them more responsible, to make them more proactive in their health. I think it's a major trend. So we're talking about shared decision making, etc. And all these tools we're talking about do help in providing information, in providing good practices. There are also social networks and communities, and this really help in breaking down this top-down connection that we used to have from the medical specialists to the patients. Now, we are conducting a reflection on how we create value. This is what we call the value-based healthcare. So this is a new metric that we didn't have before, and this is something that is more and more embedded in the way we organize our healthcare system. So yes, digital tools, I think, really helped with that, and the crisis really highlighted how communication tools, dematerialization tools, or tools which made it possible to do things remotely. So all those tools really opened up a number of avenues, and I think it's a massive major underlying trend which started maybe 10 years ago. Okay, thank you. That would be the concluding remarks of this roundtable. It was extremely rich, very interesting indeed. Now I propose once again that we have a Q&A, a few minutes dedicated to a Q&A. There are also a number of questions on the internet. Now, a question for the Minister of Health from Burkina Faso. There's a question for Tidiane. I think that we can reduce the consequences in the delay with which we care for patients. Thank you very much. Well, digital tools, when it comes to public health, I think we're going to use them more and more. And what we need are data that are collected in real time. Now, we need to make a distinction in between groups. Of course, digital tools are not here to replace the medical doctors. Now, for chronic diseases, I think that those tools can help create the right relationship with patients and to save them a trip to the hospital. So for public health, I think we can't do without those tools anymore. However, we need to have a framework around data privacy. And again, I would like to congratulate 3 of my co-workers. They are working so that we receive data in real time and in order to inform our decision making. And again, we need to be able to pool those different data sources. We also need to be supported by all bodies for digital transformation, so as to have a very good map of all available resources. Okay, so from what you're saying, I think the key word here is that we can't do without those tools now. Now, another question for yourself and for Carl Kincaid as well. So 2 territories with different infrastructures and different cultures. I have someone on the chat asking the following question. Now, health becomes more and more digital. Don't you think that access to the internet will become a prerequisite to be able to access to health? Well, there's indeed what we call this digital fracture, this digital divide. So we work on data collection so that we can inform our decision making. But as far as patients are concerned, again, digital tools are not here to replace healthcare professional. We work with Professor Gisbula, for example, on a radiology project. We have very few radiologists in our country, and so we tried to develop a platform. We tried to develop tools that would help in the interpretation of X-rays, for example. So this is rather protective of our patients because those pictures were interpreted by real doctors. So then again, I don't think that access to the internet should be a prerequisite of access to health. Now, I would like to ask a question at the other end of the world, the United States. Do you also have this question in your healthcare system? Access to digital tools, access to the internet, don't you think it's going to be a prerequisite if you want to access care?
So I think it's a tricky question, right? So in the U.S., we have parts of the U.S. that don't have internet access. But it's even more than access to the internet from an infrastructure perspective. It's also a generational thing. You know, so you have elderly populations that may not be comfortable with the internet or may not be comfortable with apps. And then you have the younger generation who expects that. You know, if you send an 18-year-old to the doctor and ask them to fill out a pile of papers, they're not going to be happy. They want an app to fill out, and they want to submit it online before going. And that's sort of the expectation. Every time I run into a doctor's office and I fill out the same forms, and parts of the forms are the same information over and over and over, I keep thinking in my mind, what are we doing? You know, and you go into a different office where it's a tablet, and you answer that question once, and it pre-populates those forms back on the back end of their system. That does many things, right? Number one, it makes a better experience for the patient. Number two, it has less errors. Number three, it's information in the system that the doctor and the leadership can see and respond to more readily and quickly. But you're always going to have some form of access to healthcare or infrastructure that doesn't allow it. So we have to expect that we will not have internet, or we will have people who don't use it. And so the system has to accommodate that. But I think with the younger generation coming up, and as infrastructure changes, that will change over time. And I know as I look back to Liberia example, if you're in Monrovia, there's decent data coverage. If you're out in the rural area, there's not. And so the expectations are different, right? And people in the rural communities go to the clinic and they get treatment directly. And people in Monrovia could do an app for at least a amount of pre-clinical information that could help serve their client their experience at the clinic or hospital. So those are all, we all want to be digital. We have to realize that's not going to always happen, at least for not a while. And but it does make the system more fluid, and it actually improves probably care, and it improves the intervention and the patient experience.
Et donc pas seulement une fracture numérique, mais aussi une fracture générationnelle. D'autres questions ici dans l'amphi. Voilà.
Yeah, so you're right. There's also a generational divide here. Now, there are a few more questions here in the room. So again, we can't give you the microphone, so you need to speak in the microphone, and the lady is holding it for you. Now, this is about the digital divide or fracture. I'm from Senegal. I am the founder of a startup, and we have to do, and we tackle the financial access to health. You know, in Senegal, there's one doctor for 10,000 inhabitants. Very recently, a friend of mine died. She was 36 of age. She has a breast cancer, and she couldn't find a doctor in due time to have a diagnosis. So she entered the health system at too late of a stage. Today, when you want to know when a drug will be available, well, in our country, WhatsApp is more and more the place to be. Today, data is the new oil. Today, poorer citizens can afford to provide information or to provide their health data. So all the questions that we are hearing here are, of course, very good, but we would love to be able to have a remote teleconsultation in our country. We are ready to send a prescription to a doctor, and we would like to have our drugs being delivered to our home because, again, we are in a state of curfew in Senegal at the moment. So the situation is such that we send the prescription via WhatsApp, then we pay with Orange money. And again, I'm not here to advocate for them, but the situation is such in Senegal at the moment. And I think that when you talk about this digital gap or digital divide, I think that there's not such a gap in Africa. You know that a number of GAFA are ready to provide internet free of charge to all African citizens. Every time you go to Africa in a number of countries, you have more and more offers whereby you have free data or free gigabytes that are being offered to you. Our population is very young. 70% of the population has a smartphone. And I think that this younger generation is ready and more than ready for remote consultation. Now, Antoine Gasbula, two things from everything that we heard: the importance of social networks, for example, WhatsApp, and the generational thing. So obviously, those GAFA once again need to be integrated in our healthcare systems, right? Well, social networks, yes, we'll need to integrate them because they are creating a community. So it's true that the social networks at the time being are being created and operated by GAFAs, but the future will tell whether new networks will be created. In our hospitals, we do have in-house social networks, if you will. The tele-expertise network that we developed in the Sahel countries are a sort of WhatsApp, and data are not hosted in vulnerable places. But anyway, about this digital gap or this digital divide, this is of course a major theme and a major topic. This digital divide has different dimensions: access to infrastructures, differences in between generations, and those differences are here to stay. What we experienced during the health crisis, we did see new forms of solidarity, and I would like to give you an example. In a hospital, we had elderly patients in a hospital, and they didn't have a smartphone, and overnight they were diagnosed as infectious, and they were not able to see their peers, their children, and so very quickly there were volunteers. Most of the time those were medicine students or administrative workers. They were ready to lend their tablets and to help those elderly people to use FaceTime and say goodbye sometimes in some situations to their children or grandchildren or what have you. So I don't think that the question of internet access will be resolved overnight. There will be access issues, but we need to also create new human solidarities, new behaviors that help in compensating for this digital divide. Well, I think that this digital differences, of course you're right, but I don't think that the digital divide will stay forever. In a matter of 5 years, the improvements have been very strong. As you said, 75% of Senegal population are connected and have smartphones. So what you're lacking is not so much smartphones, but telemedicine available in Senegal. Telemedicine in the world is one of my area of interest. Telemedicine has been around for quite a while, and it's a lot less complex than AI or algorithms. And actually, you would be surprised by the fact that there are very few countries proposing e-health services and teleconsultation. There are maybe a dozen countries with a proper telemedicine network, and I know for a fact that Senegal is not amongst those 10 or 12 countries. So there's still a lot of work in the tools. Beyond the digital divide, we still need the proper tools. So at the end of the afternoon, we do see that those tools can help bring people together. And before we conclude, we're going to go back to Lomé in Togo. Maybe they have a few questions that they'd like to ask.
Lomé au Togo, on retrouve...
Lomé in Togo, we find the students in the campus. What are your reactions after this roundtable? Lots of exchanges and discussions. Thank you so much for this wonderful roundtable and about telemedicine. And we feel that this is really going to encourage us continue what we do with telemedicine. And also some questions that have been asked really answers our own questions. So thank you everyone for giving us the floor. I'm sorry, we can hardly hear, says the interpreters.
La considération éthique et légale de la prescription médicamenteuse.
So thank you, Pierre Favre, the foundation. And the cooperation is going to be essential, especially in our activities. Thank you. So two questions also that we wanted to ask, how the cooperation, what can we do? Okay, so we will ask the questions directly. So the question of cooperation and responsibility. So of course, no one had, everybody had distance advice. Well, yes, responsibility. I think there's two questions. Questions of cooperation, prescription, the value of a prescription via telemedicine. I think the ethical question is, if I make a decision based on a less complete information as compared to a face-to-face interview with a patient. So there are limitations to what I can measure, see, perceive, understand, because I only have a screen as a contact. Am I sufficiently, I would say, aware of my reasoning, my decisions, so that I can take full responsibility for it? I think that's the essential question. I think that what we see is that indeed we can do much more than what we think with these tools, even if there are some limitations. I think that it's about, it's the doctor's choice. Does he or she think that he is doing everything to benefit the patient and he has all the information needed? What about a chatbot? A first examination, level 1 of questions or check? Well, we're far from having something that really has this ability to understand, and not just sort out. So the chatbot is good for sorting out. Of course, we're experimenting and testing work. We're also trying to see the translation, automated translations. There are some promising applications, and especially in the area of medical consultation. The field of possibilities, so you need to have a fine-tuned understanding what I call a strong intelligence. I think that for the time being, we're far from it. I think that you have to stay humble with these tools. They are very good to have specific tasks, analyze an ECG or a brain scan or derm picture, sort out, orientation for very specific tasks. That is good. We have nice progress on that. Now, when it comes to a more clinical, complex situation, I find that this is not something that the current tools can do. In the same way as how this first decision-making step You know, we see an old doctor that sees the patient coming to the waiting room and already has an idea of the diagnosis. All this phase, seeing the patient walking, we're not even aware, it's unconscious. This is something that is very important to recognize and acknowledge. And when we do telemedicine, we have to make sure that we get as many elements as possible to make sure that these mechanisms do work, because that is not what a machine can do. So I know, I'm sorry, I gave a very long answer to a short question. Then the responsibilities. There are some rules, regulations in each country, but again, we have to make sure that the person who prescribes is a qualified person for doing so. So today we have some identification or authentication, if you like, so that we can really have e-prescription. I think, you know, there's no reason for not doing that. Okay, warm applause for our questions and roundtable and panel discussion. So you can, we're almost at the conclusion of our meeting, Observatory of eHealth. So it is a time for a conclusion that someone will give us, someone who really knows Africa. So he will be 100% also native, digital native. And so also has a good view. So we're going to give the floor to Hervé Bervy, member of the parliament and economist. The LVM, République en Marche also. So he's also working with Emmanuel Macron. He has followed closely what has been said. He's also the member of the Council of the Health and also author of a report on international cooperation with France. So I'll give you the floor for the final conclusion of the meeting. So a new mic protection. Thank you everyone. Thank you all of those of you. So I have attended almost all the presentations. On Thursday, normally I go visit citizens near Paris, and so I'd like to apologize for those who, the roundtables that I have not been able to follow. But I know you are recording the meeting, so I'll be able to see you on replay. Anyhow, I just wanted really to thank the Pierre Fabre Foundation, obviously, for their quality of the meeting, and also having been able to gather so many people despite the rules, and also all the various channels. And so thanks to that, we have been able to travel from Laos to Togo, if I'm not mistaken, without forgetting Bali and so on. Anyhow, lots of countries that really, and thanks to that, we have been able to really get hands-on experience on what has been done in e-health. Also innovation and so on. So I'd really like to thank also Beatrice Garrett for the organization, all the members of the board of directors of the foundation, the minister also, so everyone who have been working at the Pierre Fabre Foundation, with whom we have been working, also the project holders, without forgetting the speakers, the lecturers, and those who are connected at home or at the office. I hope I've not left out anyone, but of course the award winners, I'd like to congratulate them. And so thanks to their wonderful work, we are able to really respond to the current challenges, and also being able to really improve the day-to-day lives of our populations, improve also the day-to-day lives of those vulnerable. I'm delighted to be with you today for two reasons. The first one, I was able to travel. I miss airports. So it's a great opportunity to leave home, get a suitcase, and get on a flight. So it's great. And also having the opportunity to really have a wealth of information, what is going on in innovation in health, what is supported, where innovation comes from. I can use it maybe as as a deputy, as an economist. I'm also a kind of voice in order to modernize these development policies, but also to tell you where we stand in terms of, I'm sorry, I don't want to give a very French vision, but at least tell you where we stand today in France and where we want to go, where we're heading. Creating partnerships with you, with the Pierre Fabre Foundation, and also all of those who are partners. Now, this day is a clear, I would say, synonym with cooperation. We saw the coronavirus crisis has more than ever shown that vaccine nationalism and insulation, being isolated, and so cooperation is so important. So we should not be isolated. And this is essential for our president, for our government, and it's also essential for foreign affairs policy. I don't want to give you lots of figures, but this year we have invested 800,000 million euros in this. So you know that in fall we have budget meetings, and so this year we decided to add 800 million euros to this in order to face global challenges, major modern challenges. We really have to invest in that. And so ever since the beginning of the mandate of Mr. Macron, over several million euros have been invested in order to really be ready for the challenges. And I'm thinking of agriculture, equality, and we are convinced that through cooperation we are able to really finance projects at the heart of the field. That's how we will be able to solve modern challenges. Now, the COVID crisis has also shown that we have, in fact, we need to modernize. We need to also have a new storytelling with new methods, and you are the ones, you are the voice, and it's always great to see new things. And so therefore we really needed to take more into account what we call citizen mobilization in the area of health, having a more, I would say, open health, and take into account health inequalities, and having a real partnership policy, creating a kind of driver. And so in order to stop being insulated, whether it's nationalism, the tempting to stay on your own, so this development policy, partnership policy was the best response that we could give. And this ability to say what our values are and what we want for future generations. So we started thinking about that way before the COVID, and as Beatrice saw and showed, that even before the COVID, we have been able to contribute to the World Fund. Contribution in France was plus 20%. Ever since we've had the COVID, we have kicked off the mass health plan, over 1.2 billion euros that have supported innovative projects. Also, people who are in this room, the idea is to take up the challenges of COVID. Now, the French president has been very much in favor of this cooperation, what we call ATTAC diagnosis vaccine launched by the WHO, and France have contributed to over 500 million euros to say that, yes, vaccines is a common good, and so no one has to be left on the side. And I know that the foundation wants to really push that study, a study that showed that if we had a nationalist policy in terms of vaccine, then we wouldn't even have efficacy of the vaccine. So on the contrary, we had to have a widespread cooperation, making sure that if we want to fight effectively, then that would work. So that is a proof via facts that partnership is the best way to go. And then we're also looking at all the help and support by the partners, and I see that the ministries here, the World Bank, WHO, and other institutions, making sure also that nothing is, really left behind. Continue to say that yes, we have to solve problems together. It seems really simple as ABC because that's what you do in your jobs, but in the case of international institutions, it's not always easy. It's not what people tend to want, and I'm thinking of leaderships and so on. So what we're trying to do also is to, at least for this year and maybe future years with the partners, and to have a more political, strategic image with this partnership. I don't want to, I don't want to do things that are only on paper at the AFD in Bercy and so on, but rather having a real fully fledged policy that is seen positively by our citizens. And that is also discussed. I think the renovation and revamping of this policy that has been really expressed by what we said today, it's a new dimension. That is why in France we're going to have what we call an orientation and programming helps to make sure that at the heart of our legislation this policy is there. There's of course the EU dimension. In France, we will have the new presidency 2022 helping development partnerships. And we see also Eastern countries. We see that it's not only relationships with Africa, with immigration and so on, whereas I find that there are other topics and not just immigration. So citizen dimension, I'm not going to go into the details because there are so many projects, and I feel that this is very good to really open up this health policy. One of the vectors for France, one of the subjects where we want to move forward. And then there's also what we call an assessment side of things, and this is what we saw today and what has also been done by several players, the discussions that we've had. The question of assessment, transparency, this is essential. The idea is to transform the political projects and having more impact in terms of partnership. And that's what we saw in Togo, in France, Lebanon, and Senegal, Laos. This is what we have to do as a decision making and put more strength, transparency. This is also the a commitment for vision and efficacy, what we're trying to do. I'm also delighted to be here today. Why? Because I can speak of a subject that is important. That is to say, innovation. Innovation, we see that even if it's a very, I would say, generic word, but innovation is a way of responding to transitions, demo transition. Via innovation, you can solve some demo pressures or demo changes. In France, I come from Brittany, And looking at, and it's also an ad. So innovation is not the magical word, but of course we have to have a partnership in France. And we have to make sure that we will succeed the several transitions that we have to face, demo, eco, and the planet. And also that is why we really push our means and also a lot of project holders. Making sure that France financing will be more dedicated to innovation. So we are able to do that, to really support our financing and also support innovation, experimentation. And that has been well explained earlier on the question of testing innovation. And also moving forward to a higher scale. What France does may be not enough, whereas the UK can do this nicely. So they have a department, that merged with the Foreign Affairs department. But anyhow, in Europe, they were holders, they were pushing this innovation that was powerful, and also that influenced also the public policies, World Bank and other, I would say, fundraisers. And so the President of the Republic has been very determined, making sure that at the heart of this French policy, the question of innovation. So it's innovation close to the field, close to the people, having this financing that finance the scaling up and the transformation in public policies. Because what is interesting is not to have several projects here and there, that's innovation, but the idea is that it's really anchored in public policy, whether it is swallowed, if you like, embedded by the states, by regions, by various, and that is transformed. So that is what we do. We have financed for this year over 1 billion euros of donations to NGOs that are also really pushing innovation. It's the first time that France does that with the AFD, and then we went from 15 million euros to 70 million euros this year in 2020 for the very innovative projects that are among and innovative projects, whether you are in France, whether you work for an embassy, if you want to knock on the door of embassies and seeing also these projects. Again, we've invested over 70 instead of 15. So we want the innovation, the field players can be really financed and could be supported. And then, of course, to support this type of innovation, we don't need loans, because that's what we tend to do. We had a partnership policy that rather used to lend money rather than gave money. And so that's why we find donations are nice. If we want innovation, it's often high-risk projects, and if it's risky, of course, we need to take that risk. And I think that we have to do it with donations, and that's why we're also having more bilateral relationship in France and financing these experimental projects, these projects that also respond to local projects. So we are working also, I think that someone has talked about this, so with the Nobel Prize winner Estelle Duflo, to have the tools that are the most adapted to finance this innovation, impact assessment, having a return on what is done, and also learning curve, and making the most on what has been done, and express this in what I call a dialogue of public policy. And I'll conclude by saying, which I find very important because it's a take-home message, is that in a way, innovation, technology, e-health, and so on, has only a benefit if it's serving public policies improving the lives of everyone, education policy, health policy, reduction of inequalities among territories. And this is the challenge. This is our work that we need to do together. Having a map where you have scattered projects, maybe successful projects or tools that are successful but are not yet connected with the states, with the what we call public policy and also private, and transform these financing of e-health projects in real dialogue of public policy with partners to improve the health of partner countries and population. Also this feedback, because we have a lot to learn from what is done elsewhere, and they could learn from us. So one of the key pillars, and this is what we should be doing in France, and Jacques Gustin will be able to testify this, is putting back some human touch to our policy expertise. I wouldn't say cooperating, but often what we see in terms of our partners is not just financing, but rather human touch, training, a real dialogue with the territories. Because I would say this triangle to really cover the question of innovation, technologies, and e-health. But again, around all this, we need to have the right financing, we need to have a good dialogue, and we need an expertise, cooperation. I would say that's what we try to support with the decree that will of course have an expertise in France, being able to really move forward to have a tool in France for financing cooperation, and also this ability to anticipate and maybe work with other countries, sharing everything that we know. So thank you very much. This is my conclusion. I know I've gone beyond my allocated time. Sorry for this. And so, of course, it was a great pleasure to be with you today. Innovation is, of course, the question of e-health is to the wonderful challenges today, the challenges of our tomorrow. So, and what we need to do together, and making sure that the EU, France, all the fundraisers, all those who want to take part, well, has to be, of course, together, because what I see today are committed people. They want to find solutions, and via commitment, via field staff, a real dialogue of public policy, and this harsh need to fight against inequalities, to improve the day-to-day lives of everyone. Thank you very much, and this is how we're going to solve the problems, because that is our key objective, is to fight against the temptation to be isolated and working together, and having a solution based on solution partnership and, of course, innovation. So thank you very much. Thank you, everyone, and have a nice evening. Bye.
Merci beaucoup Hervé Berville. Et donc avec vous se clôt.
Thank you so much. This is the conclusion of our meeting today. A warm thank you to all of you who have taken part, and we can say that these digital tools really bring people together. So it's the main message. A wonderful bravo to all the Pierre Fabre teams, because they really worked non-stop to make sure that we could have this meeting. It was not easy. Thank you to all their partners, whether it's the connected campuses. So thank you. All the technical tests, everything worked well. So it's really wonderful to have been able to get 15 countries together. So to conclude this fifth edition, I will hand it over to Béatrice Garrett, who is the director of the Pierre Fabre Foundation.
Je vais être très brève après cette magnifique conclusion.
Thank you for giving me the final word. And a warm thank you also, because I'd like to really say thank you, everyone. We know it's not easy, so thank you to all of you who have been connected, all the campuses that have been connected to share, listen, dialogue. Thanks to our prize winners. Unfortunately, we could have been all together in this room, but nonetheless, I could really maybe say next year we'll meet. If everything goes well, we could be with you. So the awards are going to be here. So we will hand over the award to Sarah. But otherwise, we will keep your awards until we meet next time. I think the day has, well, thanks to also to Lionel, our journalist, because he has animated with a perfect animation of the day, and also to all his team and the organization, technical. Also, we can count on technical, so digital does work, and I think that we did it today. And I also would like to say that today we wanted to celebrate very nice initiative. So it's important for us to have all these e-health solutions, and they could be explained by those who develop them. But also we showed that behind all of it, there's an international dimension, political also dimension, and I think it has been really shown here. More and more we felt that, I would say, we have a common destiny. I would say, unfortunately, the epidemics is here, but we need to find a joy together and solutions. So thank you. Also, you have a small coffee break if you want to have a coffee or a drink before going back home. And I say to you all, see you next year.